Well, good morning, everyone. I'm Michael McGinnis from the National Academy of Medicine, and it's my great pleasure and privilege to welcome you all to this meeting, Priorities Health on the Health Horizon, which is co-sponsored by the National Academy of Medicine and the Patient-Centered Outcomes Research Institute, and is a critical meeting at this time in the evolution of our health and healthcare priorities and our ability to respond to the challenges that have been, which the nation and the world has confronted over the past year. We've been privileged to associate with the work of the Patient-Centered Research Outcomes Institute in their effort and their activities to review their strategies and priorities over the coming years. And the work has dovetailed nicely with our work in the National Academy of Medicine to look across 9 sectors in health and healthcare and the experience that they have had in those sectors from the impact of the COVID-19 pandemic. The work in that respect has revealed a number of key challenges and opportunities for the nation in the coming years. And we want to take full advantage of those opportunities and looking to the horizon for health and healthcare in a fashion that will inform all of the key players in the sector, and in particular the work of PCORI, the Patient-Centered Outcomes Research Institute. Just a quick word on the National Academy of Medicine. We are working under the 1863 Charter of the National Academy of Sciences. Our mission is to provide advice to the nation on health, healthcare, and biomedical science. And the Leadership Consortium, which is the part of the National Academy of Medicine, is associated with this meeting in particular, is comprised of about 36 senior level representatives from those 9 different sectors, and works to ensure that we can, as a nation, do better in achieving efficiency, effectiveness, equity, and continuous learning in health throughout the nation. The consortium works in 4 different areas: evidence, digital health, health financing, and community engagement, equity and inclusion. And through the work of the various collaboratives in those areas, we partner throughout the nation with key players and stakeholders. This meeting today is an example of the best of those partnerships, and it's a pleasure for me now to introduce the Executive Director of the Patient-Centered Outcomes Research Institute, Nicaila Cook. Nicaila is still relatively new in her position. She is a wonderful leader coming with deep bench experience from many years in the National Institutes of Health and has been a splendid partner in this activity. Nicaila, it's a pleasure for us to partner with you in this.
Thank you so much, Michael, and good morning and welcome to this Priorities on the Health Horizon convening. We are really delighted to collaborate with the National Academy of Medicine on this virtual meeting, and want to thank all of you, participants, presenters, reactors, and facilitators for your preparation and lead up to this meeting. And we truly value your insights and perspectives on the trends and opportunities that can shape health and healthcare in the years ahead. And in keeping with our commitment to public transparency, we welcome all of you who are listening in to today's proceedings. And thank you for your time and your interest. And I trust it will be as informative for you as it will be for us at PCORI. PCORI is an organization that was authorized by Congress in 2010 and reauthorized in 2019, and is really governed by our healthcare stakeholders. And we fund comparative clinical effectiveness research that engages patients and stakeholders and answers real-world questions. And our mission is to help people make informed healthcare decisions and improve healthcare delivery and outcomes by producing and promoting high integrity, evidence-based information that comes from research that's guided by patients, caregivers, and the broader healthcare community. And this is the first in a series of virtual meetings that we're holding jointly with the National Academy of Medicine as part of our development of our strategic plan. And it's just one of the many ways through which we're gathering diverse perspectives to ensure that our work is really responsive to the priorities and needs of the patients and other stakeholders that PCORI it really does represent in its work. We're envisioning this next phase for PCORI really as possible because of the organization's accomplishments over the past decade, its commitment to research done differently, and its unique mission. A series of our accomplishments in the first 10 years really created this mission, vision, and values that have resonated with our stakeholders and stood the test of time. It's influenced a research culture that's underscoring the value of a patient-centered approach in research. And PCORI's delivered research results and platforms for implementation of findings for impact on patient health and healthcare. And now, after reauthorization and with committed years of funding ahead of us, we're really looking forward to move forward boldly into our next phase and accelerate our impact on care delivery and patient health outcomes by continuing to evolve in some of our major domains of engagement and innovation and dissemination and implementation. And as such, we're in the process of identifying national priorities for health that will serve as some of the foundational elements that PCORI's strategic planning efforts will then pursue, and as well as serve as a foundational element for our research agenda for the future. And so the input that's gathered here today and tomorrow are going to be summarized and presented to the PCORI Board of Governors as it continues to discuss PCORI's future. And as such, we're really pleased to have among the participants today, Dr. Christine Gertz, Chairperson of the PCORI Board of Governors, and Dr. Sharon Levine, Vice Chairperson of the board, as well as several other board members who are listening to the proceedings. So I welcome you again, and I thank you for your participation and attendance today. And it's really with much gratitude and appreciation that I will turn the meeting over to our meeting facilitator and chair, Dr. Neil Poe.
Thank you, Dr. Cook. My name is Neil Poe. I am a professor of medicine at the University of California, San Francisco, and also chief of medicine at the Priscilla Chan and Mark Zuckerberg San Francisco General Hospital. I know that is a mouthful. So, and as Dr. Cook said, my role will be to chair and facilitate this meeting. I want to thank in advance all the speakers, our panelists, and participants who have made themselves available today to be part of this important meeting. So as you all know, we're gathered here to identify and discuss some of the key issues that are on the horizon of health and healthcare. And our purpose is to inform PCORI's strategic plan that they are now developing that will help guide the Institute over the next several years. So we have 4 topics that we are going to discuss this morning. They include infrastructure, technology, social and environmental factors, and value optimization. They were designed to be macro topics, large topics that are consequential for health and health care. I want to emphasize that our meeting today is to think big, blue sky thinking, things that you may not think are achievable today, but things that we want to achieve in the future. And so with that, think about 5 years from now, hopefully after this pandemic is over, and imagine what things will be like in the year 2026. Think what you'll be doing. Think how old you might be. What's important to you? And how might all of that look a few years from now, considering where we have been over the last 5 or 10 years. So that's how, that's what we're going to ask our speakers today to do, is to consider in those 4 topic areas what might show up in our lives 5 years from now. So the way we're going to structure this is we're going to have 4 presentations on these priorities for the health horizon. Each of our speakers will have 20 minutes for those. We'll have an opportunity to have a few clarifying questions after each presentation, really to clarify what the speakers have done, not necessarily to comment directly, because after that, we're going to have 5 stakeholders who will offer their perspectives on trends and opportunities in health and health care. And then I'll have some closing remarks at the end. We'll have a short break, as you can see, in between our our overview presentations and our stakeholder perspectives. Just some logistics. I'm going to ask the speakers to turn their video on when speaking, but otherwise to remain muted so we don't have disruptions. Let's get started. A few other logistics for our participants. We'll have questions and answers, as I said, on the presentations. Audience members who wish to offer comments can use the chat function located in the controls at the bottom of the screen on the Zoom platform. However, because of the nature of this meeting, really the size and limited time, we won't be able to address audience questions in real time. But be assured that National Academy of Medicine staff will record those comments posed in the question and answers, even if they're not directly addressed in this live meeting. We will have a recording and copy of the presentations that will be available to view after the event. So those are our logistics. So let me get on to introducing our thought leaders today, who will set the stage for the rest of the meeting. And as I said, their presentations are going to touch on multiple aspects surrounding the current state and potential of our 4 areas. Our first speaker will be Dr. Rachel Hardiman, who is a reproductive health equity researcher and the Blue Cross Endowed Professor of Health and Racial Equity at the University of Minnesota School of Public Health. And she will address social and environmental factors. Our second speaker will be Dr. Joshua Denny, a physician scientist and the Chief Executive Officer of the NIH All of Us research program, and he will present on technologies. Third will be Dr. David Mulstein, the Chief Strategy and Chief Research Officer at Levitt Partners and a visiting fellow at the Accountable Care Learning Collaborative. And Dr. Mulstein will address optimizing value. And last but not least will be Dr. Renu Kushal, who is Senior Associate Dean of Clinical Research and Chair of the Department of Population Health Science and Physician-in-Chief of Population Health Sciences at the Weill Cornell School of Medicine. And she will present on infrastructure. So each presenter will have, as I said, will have 20 minutes. Remind everyone to mute their lines, but unmute when it's your turn to present. And our Academy staff will control the slide deck, and our speakers are encouraged to indicate when they want to advance to the next slide. Let's start off. Dr. Hardiman, pleasure to welcome you and hear your remarks.
Thanks so much for having me. Good morning, everyone. I'm really happy to be here with you all today to share my thoughts on the social and environmental issues that impact health and well-being, and particularly my thoughts on our path towards creating health equity. As you heard, we only have 20 minutes, and so my goal is to offer a breadth and not a depth of knowledge right now, with the hopes that we can continue the work of digging into these important issues. So with that, I'll move to my next slide. So I opened today with this quote from the late author Toni Morrison from her book Paradise. She says, "The only way to change the order," she thought, "was not to do something differently, but to do a different thing." And my colleagues and I actually started a paper we recently published entitled "Fighting for America's Paradise" with this quote, because in fighting for the health and well-being of Black and Brown communities, and in turn the health of our nation, we must indeed do a different thing. That is, we must address the social, environmental, economic, political, legal, educational, and healthcare systems that uphold structural inequity and structural racism. And so to be clear at the outset of this presentation, any of and all solutions to eliminate racial and health inequities and achieve paradise, as Toni Morrison describes, must be rooted in the material conditions in which those inequities thrive. Next slide, please. So my goal for us today in our 20 minutes together is to describe the acute and longstanding health inequities that are caused or exacerbated by structural racism, to understand how the conditions of daily life, those social determinants experienced by historically oppressed groups, have their roots in structural racism and thus impact health and well-being, and to offer insight into opportunities for improvement and transformation. Next slide, please. So this quote is an important one because, first and foremost, our understanding of the social determinants of health are not merely facts to be known, but indeed the conditions of people's lives that must be challenged and disrupted. And so in this 2018 paper, Sharma and colleagues say, in many ways, the current approach to the social determinants of health within medical education, and I would offer, I think beyond medical education certainly, positions them as facts to be known, rather than as conditions to be challenged and changed. We need to be talking about poverty, or we often talk about poverty, but not oppression, race, but not racism, sex, but not sexism, and homosexuality, but not homophobia. And so I say this to encourage us to be thinking about not just these issues, right, but also the institutions and the structures that uphold and perpetuate them along the way, because that's where our focus needs to be as we move towards building health equity. Next slide, please. So I think all of us on this webinar this morning are likely familiar with the term, the social determinants of health. So the notion that where we live, where we work, play matters for health and well-being, and this idea that our health does not occur in a vacuum. So just as this diagram shows the social determinants of health, like education access to quality healthcare, housing affordability, work, neighborhood context, so where you live, your social interactions, all can contribute to inequitable health outcomes. But what I would ask you to think about is, have you ever stepped back to ask the question why? So why do the social determinants matter for health? And if we were in a dialogue face-to-face having this discussion, I would ask for folks to sort of shout out their thoughts on why. But instead, since we're in this virtual space, I'm gonna walk you through a brief example of why the social determinants dictate health outcomes. Next slide, please. So again, we know that where someone lives matters for their health. We have seen incredible studies, looking at zip codes and matching them with life expectancy, and have seen the fact that from one zip code to the next, there are potential for health inequities there. My own work has, for instance, shown that living in certain neighborhoods here in the Twin Cities puts one at greater exposure to police surveillance, and we find that disproportionate exposure to police surveillance is associated with higher rates of preterm birth. So, where we live matters for health, but we have to understand the history behind that. How did that become the case? How did that become our reality? And one of the ways that that's become our reality is due to redlining. So the act of literally drawing lines on maps to separate hazardous and declining neighborhoods from those that were considered desirable and the best. And that created these codified patterns of racial segregation and disparities, created disparities in access to credit in our country. And what that resulted in is differences in the level of racial segregation in home ownership rates, home values, certainly credit scores. And even today in 2021, it's still apparent where these boundaries have been drawn in many communities. That legacy of segregation and now gentrification and environmental racism and local zoning ordinances all are directly tied to a policy called redlining. And I think it's important to think about this within the current context of COVID-19 and its disproportionate impact on Black communities and Indigenous and Latinx communities as well. We see that, Black populations have higher rates of asthma and cancer, and recent data have suggested that chronic exposure to particulate matter in the air may contribute to a risk of death from COVID-19 as much as 15% higher for Black Americans than that of their white counterparts. We also see where researchers have directly mapped COVID rates and COVID mortality based on redlining communities and see a significant relationship there as well. Next slide, please. So redlining is one of the many forms of structural racism, a policy that's baked into our systems and our institutions that has, over time eroded and contributed to poor health outcomes. And so what I think is important to understand, going back to that, question I posed, why do the social determinants matter for health? It's because at the root cause of the social determinants is structural racism. And that has dictated why social and environmental context are factors for health and well-being. Next slide, please. So I just want to be clear, I think definitions and language are incredibly important. And when I'm referring to structural racism, I'm referring to a system that's built on white supremacy that has structured opportunity and advantage for some and disadvantage and lack of opportunity for others. I would offer that it's a fundamental cause of racial inequities in health, and it undermines the health and well-being and the ability to ensure that everyone in our communities, everyone in our nation thrives. And dismantling structural racism is contingent upon our ability to create healthcare institutions, to create communities and neighborhoods and policies that enforce equity and defend against discrimination as we forge a new path together. Next slide, please. So I often include a deep historical context in my talks around structural racism as a fundamental cause of health inequities, because I think we can't do this work without understanding our history. I didn't include much of that here just for the sake of time. And so I think, what I think is important to remind folks of is that the history of our country, the 400 plus years of inequity that's baked into our country, we're seeing it play out in very real time. And this is an important example of that. So, Kaiser just released their data on who's getting vaccinated. And I think it's incredibly important to look at, for instance, the District of Columbia, Washington, D.C., that has a deep history of redlining and racial segregation. And so what we see here is that, Black people in the District of Columbia have 76% of COVID deaths. 49%, so nearly half of the cases of COVID in the district, but only 26% of access to vaccinations. And so, I think we have a very real opportunity and very real time right now to think about how do we infuse equity and an anti-racist approach into our healthcare systems and into our policies to think about how to do vaccine distribution certainly more equitably, given what we see as sort of the historic and the legacy of racism and how it's impacted health, and then how it's playing out in contemporary times. Next slide, please. So again, structural racism is really about this normalization and legitimization of an array of dynamics, whether they're historical, whether they're cultural, institutional, as well as interpersonal, that are routinely advantaging white people while producing cumulative and chronic disadvantage for people of color, which certainly is wearing and tearing on health and well-being. And I share this, this image because I think it's important to understand that structural racism is not only the history and the policies and the practices, but it's also how we are primed to think about who's in our in-group and who's in our out-group. And that's how we make assumptions and associations about people as we move through the world, as we move through our work. And so, being able to understand the role that implicit bias plays within the broader context of structural racism is incredibly important. And I think our success in creating, certainly healthcare organizations and models of care in which everyone has access to the opportunities that they need to thrive is contingent on our willingness and our ability to both confront the history and impacts of structural racism, but also to learn how implicit bias operates and takes, how it operates within the system, so that we can take action to interrupt racism on all of the levels and the ways it shows up in our work. Next slide, please. And, going back to that historical context that I mentioned is so important. I always make it a point to show this timeline, or these two timelines, because I think we need to remember how deeply ingrained these issues are in our history, and how they've taken new shapes and forms over the years in order to maintain the status quo, and that we have a very real opportunity in this moment to change that, to change the course of history, and to do things differently, as I said when I opened my talk. And so, just as a reminder, nearly 80% of our history is based on slavery, and then we see all of the ways that racism has taken different forms over the years. Next slide, please. So, given that history, right, where are we now? And I've spent, my career thinking about and researching this issue. And when I came into the field, I came in on the shoulders of incredible mentors and scholars and colleagues who had done a lot of work to document merely the fact that there's racial inequities or racial disparities in health and healthcare delivery. And I think we've moved forward from there, right? It's taken time, it's taken intentionality. And I think we're at a place where you see the red dot there, where we are having discussions about racism as a fundamental cause of health inequities in our communities and in our country. And I look forward to the future and contributing to the work moving forward. And so with that, I will move to the next slide and share just some of my thoughts on our opportunities for improvement and transformation as we do this work. And I start with actually personal transformation, because I think that we can't do the work of addressing the social and environmental factors of health and well-being and dismantling structural racism without having done the work ourselves to really think about what our role is in dismantling structural racism. So I wrote this piece. I wrote this piece in 2016, just after Philando Castile was shot and killed by a police officer about a half a mile from my office here in the Twin Cities. And our goal was to ensure that our colleagues recognize that we cannot live our lives as though we don't have a role to play in this work. So we wrote this call to action, laying out these steps of learning about and understanding and accepting the United States racist roots. So that historical piece that I mentioned several times already, that we have to understand how racism has shaped our narrative about health disparities, that we have to define and name racism. So much of, I had just had a great conversation with my students this morning prior to this presentation about the sort of lack of consensus around language and naming racism, and really being clear about what we're talking about and coming to a consensus sort of as a field around that. And also recognizing racism, not just race. So being able to understand that it's not Black skin that causes, or brown skin that causes someone to be at risk for COVID or for maternal death. It's the process of what happens by living in a community or in a society that does not value Black skin. It's racism that is the risk factor. And then the last piece of our call to action in 2016 was that we have to center at the margins. That is, we have to shift our viewpoint from a majority group's perspective to that of marginalized groups. What we know is that historical and contemporary views of economics, politics, and culture are informed by centuries of explicit and implicit racial bias and racism. And as a result, it normalizes the white experience. It makes the white experience the standard. And without having diverse viewpoints at the table, and not just at the table, but leading the work, we're not going to be able to move forward. Next slide, please. And this is just a quick example of that. So the first study documenting racial disparities in NIH funding came out in 2011. And that study showed that award probability for Black principal investigators from 2000 to 2006 was approximately 55% that of white PIs of similar academic achievement. And over a decade later, we see that this gap persists. In 2014 to 2016, Black applicants' award rates remained at approximately 50% of those of their white counterparts at the NIH. So thinking about the fact that, diversity in funding and who's funded and who gets to lead the work is going to certainly lead to more diverse thoughts and diverse opportunities for improvement and transformation, and certainly greater innovation. Next slide, please. And then, I think we have a lot of opportunities for transformation as researchers, for those of us who are conducting research in the field of health equity. And actually, even if you're don't see yourself as a health equity researcher, if we're studying health in some way, we have to be paying attention to these issues. And so in this paper that I published with one of my doctoral students in the journal Health Services Research, we share opportunities for research transformation. And we explain that, predominant notions about race shape the way that we as researchers frame our questions. For example, research questions are often phrased as sort of what causes Black people or brown people to have so many disadvantages compared to whites. So going back to that, whiteness as the standard and what forces are at work. And, this question or variations of this question are, on the surface appear to be sort of innocuous. However, in reality, this type of question ends up reinforcing racism and white supremacy by suggesting that there is or perpetuating this narrative that there's a Black deficit and subtly reinforcing sort of that deficit and that story. And so I think we have some real opportunities to embark in anti-racist research and to really think about the ways that we're conducting our research, our methodology. So if we know that racism causes health inequities, we have to consider both developing better ways to measure systems of inequity and name racism as that central concept, and also to think about what it means for the interpretation of our findings. There's often this conflation of race with racism in the interpretation of our research findings. And I think we have some real opportunities to shift that. And we close this piece by talking about this idea of the emancipation from the dominant frame, meaning that we need to critically analyze the questions of the question of whose evidence do we consider to be real. So, certainly in the academy and in health services research where I sit, there's sort of this implicit agreement regarding who's able to generate evidence, and by extension, whose evidence is real and who's not. And we haven't fully stepped back to say what's missing, who's missing, and who should be both, again, at the table and leading the work. And so I think we have some very real opportunities to transform the ways that we approach our research and our research studies in this space. Next slide, please. So health systems transformation. This is also a piece that I published with colleagues in the New England Journal of Medicine just after George Floyd's death in in my community, in my childhood neighborhood, actually, in this past May. And in this piece, we highlight the intersections of COVID-19 and police violence and offer opportunities for health systems transformation and directions for our field to consider. And I include this because I think what we offer in this piece and the discussions I've had since then suggest that there's some very real opportunities for movement and transformation within our healthcare systems based on what we share here. And we start by explaining that, we have to divest from racial health inequities because they're not signs of a system malfunction. We often talk about our broken system, but in reality, they're a byproduct of a healthcare system that's functioning as intended. And what that means is, and I think this goes back to being able to understand the history of how our healthcare systems have been built and the harm that has happened along the way at the expense of Black health and Black bodies. And by reckoning with that and divesting from that, we are able to move forward in sort of real and authentic ways. We also, I would also encourage us to consider how we desegregate the healthcare workforce. And I know this has been an ongoing discussion for as long as I can remember and before, certainly. What we know is that the healthcare workforce is predominantly white at essentially every level, from student, staff to CEO. And that lack of diversity has to be understood as a form of racial exclusion that affects economic mobility and the health of people of color, especially given that healthcare systems are often the economic engines and largest employers in their communities. And I think that there's a real opportunity to think about diversifying our healthcare workforce beyond simply saying, well, we need to get, the refrain that we need to get more Black doctors or doctors of color into the field. I think it means something across roles within healthcare, and also tying that back to the fact that it could have a significant impact on the social determinants of health. By giving someone a job in healthcare that's stable and where they're insured is certainly going to impact perhaps where they're able to live and buy a home, where there are opportunities to send their kids to different schools, or to support a tax base in a community where a healthcare system or a hospital is part of the economic engine of the community. We also offer that we need to be thinking about how to make mastering the health effects of structural racism a professional medical competency. Medical schools and training programs, and I would even say hospital systems and clinics have a moral imperative, frankly, to equip every clinician and every staff member in every role with the ability and the skill set and the knowledge base to address racism. And it should be tied to licensing and accreditation, and qualifying procedures should test this knowledge as an essential professional competency in the same way other professional competencies are tested. And then we also, related to that, we need to be thinking about how we mandate and measure equitable outcomes. So just as healthcare systems are required to meet rigorous safety and quality performance standards for accreditation, they should be required to meet rigorous standards for addressing structural racism and achieving equity and outcomes as well. And finally, we close with that piece by just offering the simple fact that our role as health systems is to protect and serve. And that means, even means protecting and advocating for patients, including victims of state-sanctioned violence. Next slide, please. And I recognize that I'm probably running out of time. This is my last slide. I had a few others that I'll skip, but I think, so I've offered some health transformation, health systems transformation ideas, some research transformation, personal transformation, and all of that is certainly tied to policy and how we enact policy, both at a state and a national level. But I also just wanted to include a few final thoughts around policy opportunities that I see sort of at the forefront right now. And this is based on the article I referenced when I opened my talk, this paper that we recently published in the Journal of Health Politics, Policy and Law, in response to the question, how should the new administration, the Biden-Harris administration, be thinking about and addressing structural racism as a fundamental cause of racial health inequities in our country. And, certainly, at the top of that list is a comprehensive COVID response. And I won't go into detail in any of these, but just for the sake of time, we also, I think there's a real need for a White House Office of Racial Equity that is fully focused on thinking about how to achieve equity and to intervene on these social determinants and their root cause. Part of that will require thinking about universal comprehensive single payer healthcare and prioritizing, again, those policies that support the social determinants of health. And I think I'll leave you with probably what's the most controversial or provocative thought within this paper. And that's, I think reparations has to be on the table if we're going to think about how to close the intergenerational wealth gap and to really, truly intervene on the social determinants of health and the fact that social and environmental context matters so much for health and well-being. A discussion of reparations has to be a part of that. And so, I will just close with, I hope that these big thoughts and these big ideas are helpful and useful. It is part of the vision. I think we can get there. I think dismantling structural racism is certainly contingent on our ability to create systems and institutions and policies that lead with equity and enforce equity throughout. And, given the complex and insidious and systemic nature of racism, we need to be intentional in our work in this space. And I look forward to future work conversations and initiatives. So thank you for having me. You can head to the next slide. And I look forward to your questions. Thanks.
Thank you, Dr. Hardiman. You've given us a lot to think about for the future and much to achieve. So let me ask our meeting participants whether they have any questions for Dr. Hardiman. And you could, probably the best way to do this is to raise your hand in the reaction section at the bottom of your screen. Yeah, so Dr. Adler-Milstein, why don't you ask your question?
Sure. Thank you so much. That was just an incredible talk, and I feel like I really learned so much, despite feeling like there's already so much important work to do. My question: I was really intrigued by your notion of sort of having this be part of accreditation, because that is so central to priorities and what people are focused on, especially within health systems. And I was just curious whether you had ideas for sort of the measures, or because ultimately we teach to the test, and so like the measures would become so important there. I was just curious sort of your sense of where we are with respect to having measures that we could really orient health systems around, that they could be held accountable for.
Yeah, that's a great question, and one that I am having a lot of discussions with folks across the country about right now, because I think that the measures have to reflect both what's happening within the institution, whether it's around hiring practices, diversity, and sort of the workforce, and how even down to sort of how quality improvement efforts are conducted in in various subspecialties and things like that. And but also I think they have to the measures have to also be reflective of the community, the surrounding community that a hospital system or healthcare system is serving, to be able to say that they're being responsive fully, right, to both their role as sort of a, again, an economic engine in the community, and a provider in the community, as well as what's happening. And so, as well as what's happening sort of within the walls. And so I'm hesitating to offer specific examples right now because it's still a work in progress, and I don't want to like throw folks' ideas, out there. But it is something that I'm having a lot of conversations and working on right now.
Thank you. Any other clarifying questions? Okay, well, seeing none, thank you, Dr. Hardiman, for those comments. I think will all give us a lot to think about. So let's move on to our next speaker, who is Dr. Joshua Denny. So Dr. Denny.
Wonderful. I see you got my slides up, and I assume everyone can hear me now. Thank you so much for the invitation to be here today and talk through this very important topic. And my focus is going to zero in on technology. And I'm going to use the lens of the All of Us research program as part of how to facilitate that conversation. You can go ahead and go to the next slide. All right. So as we think about the All of Us research program, our mission is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. And that really starts with nurturing relationships with our participants. We aim to recruit 1 million or more participants as partners with our program, and they have been really partners with us in all levels of governance and creation of our core protocol, and all of our meetings through the process. We have involved participants and participant ambassadors through that process. And then we think of it as an ecosystem that really wants to link providers and groups like the NIH and others with the people who use the data, and for the data set to grow richer over time, and then deliver this large, rich biomedical data set into as many hands as possible. And I think this is a paradigm of how we will see research be done on platforms as we move forward. And also a way to do so to help preserve privacy and trust and make compute and researcher access more equitable. We see these as foundations. We'll talk more about this as we talk. Next slide. So the summary of our protocol here and where we are. So I mentioned our goal is to seek 1 million or more participants. We've really focused on diversity on this aspect. It's disease agnostic in all health stages. We believe by collecting individuals early and following over time, it enables us to do all sorts of kind of research on that, and facilitates asking of questions that you don't anticipate you'll need to ask. We launched in 2018 and currently have over 370,000 participants, over 274,000 that completed all the initial steps. I mentioned our focus on diversity, and we've recruited in more than 50% diverse by race and ethnicity, and over 80% by a more inclusive definition and more expansive definition of those who would be underrepresented by medical research, which looks at not just race, ethnicity, but also sexual gender minorities, rural location, low education attainment, and socioeconomic status, and disability. We believe return of value is very important, so we give data back to participants, genetics being a key part of that, and thinking about EHR data and others. And then the individuals who join are longitudinal, enrolled, and recontactable. And one of the things that I think is important about this as we think about the future of where research is done is how we're trying to recruit people and have them contribute data into the resource. So we recruit through traditional healthcare provider organizations, large academic medical centers, those sorts of things. But we also have pathways for people to directly volunteer into the program. And there's very much intentionally an arrow between there, because we want to see, we imagine the journey as someone may enroll at a healthcare facility, but they may find it more easily to donate another biospecimen through the mail, or maybe go to a convenience clinic instead of actually showing back up to the academic health center, or they may move to a different area of the country. And so we need to support that through a variety of mechanisms. Regardless of how you come in, essentially you share the same basic sets of information, which we'll kind of walk through as we go through. What we highlight here is, most of that doesn't need an in-person visit. And as we think about the future of what happens with healthcare and research, I think we'll see increasingly less reliance on the in-person visit, because that's such a small fraction of the healthcare we receive. Next slide. So this just gives a map that's not current, but gives you a sense of where we have sites across the country, and the pluses represent more traditional healthcare systems, and then all the dots represent a smattering of clinics that were in acute care kind of facilities, and then kind of minute clinics that we would associate with across the country. And the gray you're overlaying is population density. So you can see that they're kind of mapped there. In addition, we have general mail, such as sending saliva kits to mail to participants so we can reach them anywhere. Next slide. So as we talk about the data that we have in all of us, it starts with the consent process, which is a broad consent process, authorization to use electronic health records, a set of surveys, and that goes on over time, physical measurements, biosamples, which we collect blood and urine and saliva, and that may be different from individual, mobile and wearable technologies, which we'll talk a little bit more about later. And as we think about the elements, I'm just really harkening back to some of the elements that Dr. Hardiman mentioned. It's not just about biology. It's not just about sort of the elements that we collect from the electronic health record. It's really getting deep into thinking about over time the environment, lifestyle, the kinds of things you can supplement with questions and measurements, as well as the data that we can collect. Next slide. So as we talk about the mobile and wearable tech pieces of this, through our web device, our phone applications in the web, we have the ability to link in currently Fitbit devices and Apple Health Kit. Apple Health Kit gets you both linkages to healthcare records if you share that through your device, and then also other devices that link in through Apple Health Kit, such as other fitness trackers. And you can see that this is very much a proactive, participant-driven component where they choose to share the information. They can choose to unshare it. And I think this is a paradigm of we'll see increasing this kind of element over time. So far, about 14,000 people have chosen to share information. We haven't really pushed this very hard, but about 14,000 people have found this part of the site and share their device information. And we just launched a pilot to distribute another 10,000 Fitbit devices to individuals that launched a couple of weeks ago. And so people are signing up for that, will be receiving those devices and sharing them with us. Next slide. And I mentioned that return of value is very important to our program. And when we started it, we did 77 community engagement studios across 17 cities before we enrolled anyone. And we asked 4 major questions in those studios, one of which is, how do we provide value to you? And what would be an incentive to become part of the program? One of the things we heard back, and amongst the top 2 things we heard from most populations, had to do with getting information back, like genetic results, especially health-related genetic results. People are also interested in availability of clinical trials, health information, access to their EHR, non-health related genetic results. But one of the things that they told us was the ability to actually have access to information they don't know about themselves other ways, and that we are pursuing in the program was important to them and valuable to them. So one of the areas we prioritize return in has been these genetic results. And so we have non-health related genetic results and we have health related genetic results. The non-health related are driven by genotyping arrays. All the data from our genome centers goes through our data and research center. And then we deliver ancestry, genetic ancestry and traits that we launched in December. Those results are going back to participants now, and you'll see some more in the later slides about that. It's been received very well. An important part of delivering any of these protocols has been working with our participant populations and really making sure that the information we're delivering is understandable, is sensitive, especially when you think about genetic ancestry, gets at some of the hard things. that are in our past, like Dr. Hardiman mentioned, as well as providing this information that people are interested in finding out. And then the health-related genetic results is something we've put really considerable more effort into figuring out how to do this because of its implications. We have an FDA investigational device exemption for what we're doing, and then we're using CLIA labs to generate the results. And we're focused on two categories. One would be so-called ACMG59, which are 59 genes that are related to things like inherited cancer syndromes and cardiomyopathies, arrhythmias, for which rare variants are found that could change outcomes that we have interventions for. And then pharmacogenetics, so genetic variants that alter drug prescribing potentially in individuals. Both of these are being designed with participant input, of course, the FDA oversight, and we also have a genetic counseling resource as part of our program that will be available to anyone that has questions and actually be involved directly in the return of all the ACMG 59 results. We anticipate launching that in about a year. Next slide. This just gives you a little bit of overview about the genetic ancestry and traits component. I'm showing one of the 4 traits we're making available to our participants now, cilantro preference, and just kind of tells you whether you're genetically likely to be able to taste cilantro, whether it tastes like soap. We are, as of early March, we have genotyped about 37,000 people. We're approaching 20,000 for whom we've generated whole genome sequences. And amongst the people who are eligible at this point, about 70% of them have viewed their genetic ancestry and/or traits. You can see that there's slightly more people choosing to view genetic ancestry than their traits. Overall, this has been well received. The vast majority of people feel like this agrees with their experience, including like whether or not they can taste cilantro. We have found, importantly, I think that about 97% of our participants, when they go through the informing loops of whether or not they want to receive this information or not, decide that they want to receive the information. And that's pretty consistent across all of our demographic and underrepresented in biomedical research components that we measure. Essentially, it's a pretty uniform distribution of who wants that data back. Next slide. So now I'm going to talk a little bit about the data that we get, and this is this talks about where we are and where we're headed. And I think this is a paradigm of how the data will grow over time. So from our academic health providers and other healthcare systems, we started with getting more structured kind of information. These data are mapped into common data models, but we hope to move, over time to narrative data and image data and other kind of registry data that might be held at healthcare provider organizations. These are provided in maybe the more traditional model of research where you have a data provider sharing data to a central repository, and they're in charge of harmonizing the data and that kind of thing, and a joint process of quality control. And then there's amount of data that we will add centrally as a program, and data linkages are very important and are becoming more important as we think about health sciences and research in this domain. But on the right, I have kind of more participant provided information, and that starts with the idea of electronic health record uploads and the standards that are being promoted by the ONC for representation data, and being able to share those are part of that. And so you can go through, I mentioned the Apple Health Kit component, where you can go through and link in through your phone and then link to a different institution. And we're going to be building in those kinds of things outside of Apple Health Kit as well, to allow people to link directly from our resource into those. And they require you to confirm and sign into your patient portal at the healthcare center to share those data. As people move around the country, that's probably a very important aspect of how we could collect data. And then we talked already about, uploading of Fitbit data, and we imagine that kind of domain of space of biosensors and even health-related prescribed devices such as glucose monitors and things like that being ways that participants could directly share health data. And then we have sharing of biospecimens and in-person exams, and that will obviously continue to be part of healthcare. All those data as they come in need to be harmonized. We also want to think about, how do you protect privacy? And some of that is through de-identification and blurring of data and matching, maybe the kind of blurring and de-identification you need to the analysis you need to do. So a lot of analyses don't need exact dates. But some do. Certainly we think about COVID, you want to know dates. But if you're thinking about heart disease, you may not need to know time of year. And so those kinds of things, you can think about how you can privacy protect your data, matching to the use case. And that's where you think about even having multiple curated data repositories and then a variety of tools to use the data. Next slide. So harmonization of data is challenging, and I think of it as a journey, not a destination. We have 16 different EHR vendor platforms that are donating data to us. And each of these needs to be mapped into a common data model. In addition, each of these installations often have local configurations and local differences that have to be harmonized. This common data model approach is an important one, which you'll probably hear more about through this time here. And when I talk about it being a journey and destination, look at the columns in that grid on the right. So, as we get more green, we're getting a higher quality of data, more harmonized data. You can see that, the data generally is getting more green, but sometimes it gets a little bit worse as new data come in, as new data types are introduced, as new facilities upload data to us. And each of this requires a lot of work at the sites as well as work centrally to harmonize. Next slide. The advantage of having all this extant data is you have data potentially going back decades. And this just highlights, even though our participants really started joining in large numbers in 2018, you have decades of data going back retrospectively, even though we currently are only enrolling adults, for instance, 18 and over. We have individuals who have shared data dating back, to birth. And so we are able to do analyses of pediatric trends in body mass index or antibiotic usage or things like that, just from exact data that people have shared, as well as doing in silico sort of prospective analyses of different elements with that EHR data and other kinds of data that could be linked in. You can imagine environmental exposures and things like that as well. It doesn't change the need for prospective studies, but it adds a lot of power to the retrospective analysis. Next slide. The next thing I want to talk about is how we do this sort of data. So a lot of times the analysis, as we think about it, the traditional model has been for a number of researchers to authenticate, to apply, and then download the data. That discourages shared research. It also means that your weakest link is whoever has downloaded the data into the least secure environment in terms of privacy and protecting it. And that also means each of the researchers has to have a huge infrastructure to analyze it, especially when you think about the scope of these huge data sets we're getting now. You have to pay for multiple copies, different places, and there could be lots of tools differences that people use. It also hinders reproducibility. Our model has been a cloud-centric model where you try to bring researchers to the data. There are 4 databases imaged there because it doesn't necessarily mean that all the data has to be centralized. You could actually still have a federated model, but the idea is that the data don't have to leave where they are instantiated for researchers to get access to it. And that facilitates collaboration. It allows more centrally monitored and enforced privacy and security protocols, and allows researchers to have more equitable access to the data and more equitable access to computing platforms. Next slide. So this is just a screenshot of ours. These are growing in terms of having cloud-based researcher environment. In ours, it's a central resource. We have also invoked a passport access model, so we validate who the person is. We teach them, kind of what kinds of research they can do on the platform, and then they can create a number of different protocols, essentially, of what they want to do. Those are all exposed on the website, and you can see that. And then they can be audited because it's in a cloud model. And so it really facilitates, we believe, their scientific investigation. And we do have an institutional agreement. You can see that over 650 folks have joined, creating over 450 workspaces since we launched in March. Since we launched in May of last year. Next slide. As we think about the primary scientific utility of this, we think about these 5 domains. So in this case, this is infectious disease example, but we're disease agnostic. So we think about treatment and outcomes, diagnosis, risk prevention, and then we think important aspects, as really highlighted by the last talk, health equity, and then beyond sort of disease prevention, wellness and resilience. So what kind of overriding themes do you have maybe as response to disease and how you can recover from it? Next slide. And so I'm going to give you an example of research a finishing PhD student of mine presented to me on Friday. So Patrick Wu, he passed his dissertation defense, so soon to be PhD, presented these data Friday, where he had done this study within the Vanderbilt resource, looking at potential drug repurposing, and was looking at change of LDL cholesterol, and did combine some genetics and other factors to it. The important thing I want to highlight is this is showing clinical effects. And he did this originally at Vanderbilt. Next slide. And he was able to quickly take that data and take his code that he wrote at Vanderbilt and then apply it in all of us. Advance. And essentially, within the code that he wrote for Vanderbilt, he basically, if you could hit next on here, he just had to change basically the table names only, and then the code basically worked. And so he was able to replicate this in the All of Us resource because of common data models very rapidly. And of course, this has been seen other places, but it just gives you an example of how he could take something with a cloud-based model and really within a week or so have a replication across 50 different EHR systems. Next slide. And next slide. And so as we think about precision medicine in 2030, so thinking about 10 years in advance of where we are, this is from a perspective that Francis Collins and I have written, and we came up with kind of pulling these things together, which hopefully you've seen some examples through here of 7 ways we think that precision medicine will be important to transform healthcare. So the first are huge interoperable research cohorts, such as All of Us, the UK Biobank, Million Veterans Program, PCORI. All these kinds of efforts are really huge and important to provide diverse sampling of the variability in genetics, environment, and lifestyle. You don't need representation, you need reflection of the diversity across the world in all these different elements. Importance of improved diversity and inclusion in science. You just heard a wonderful presentation about that, and its importance not just in participants, but also in researchers in the researcher community. That's really going to be essential. It's important not just within, it's hugely important in the United States, it's also hugely important in the world, and how we think about how we include those across the world. Next is improved, I think we'll see routine use of clinical genomic testing to guide prevention, diagnosis, and therapy. Right now, it's mostly focused on cancer therapy. You could think for a lot of genetic testing and then rare genetic disease. We think that this will become commonplace. We've talked a lot about big data and artificial intelligence. We have all seen this, and it's exploded in the resource in the community. We think this will increasingly come to be applied to healthcare across both structured information and increasingly unstructured information. You have to think about the technological infrastructure needs for this. Again, it is a reason to think towards cloud computing models. Electronic health records have been a really important source for phenomic information, especially about disease statuses, but it will become a very important component for genomic research as well, especially as you think about what we have seen, and to number 3, with the growth of genetic testing. Genetic testing from clinical care will rapidly outpace research applications and research cohorts. So if we can use the clinical genetic testing that will happen, that will dramatically improve our power. In addition, most healthcare, as we all know, occurs outside of healthcare centers. So I think we'll see EHRs become and grow to incorporate, just like all of us has data provided from participants directly, whether that be through interactions with participant portal, sharing of activity monitor, other biosensor data, much as even we do right now with interrogation of ICDs and other implantable devices. We could see remote interrogation like that happen and collection of those data in the EHRs across so many more diseases. As we collect these biosensors and other ways and measures, I think we'll have a higher variety, higher resolution phenomic investigation and environmental exposure data, and that will feed both clinical and research use. And data linkage is an important part of this. And I want to highlight here precision nutrition as well. And what we eat is the most commonly, sort of exposed exogenous set of compounds and fundamental to what we do, and what can we learn about that. We will have many more powerful ways to think about that, I think, over time. And then privacy, participant trust, and returning value. I think just echoing the theme that from the last talk here, and really through a lot of the foundation we've built on with all of us. And that comes around, it has a technology piece, it has policy pieces, it has outreach pieces, it has engagement pieces. We have to think about those working together. Next slide. Just thinking about the clinical applications of now and where we'll be in 2030, and highlighting a few of them. For genomics of disease, it's primarily a select set of rare disease and cancers at this point, but we see it becoming routine. I think beyond just from host genomics to microbiome measures, and other molecular measures that will come into play, as well as epigenomic and things like that. Pharmacogenomics is pretty rare right now, but could become increasingly common. Data would suggest all of us harbor pharmacogenomic variants that would alter drug prescribing. And in fact, based on what we know and how drugs have been tested, it's more common against more commonly found in minority populations than those who've been traditionally represented in biomedical research. So it's another way we can counter an element of structural racism by more exact and thoughtful prescribing. Genomics for healthy individuals, I think we'll see increasingly growing numbers of stories around genetic research, and the percentage of people who are affected, we will recognize more. Before I moved to the NIH, we identified a woman at age 80 who was a new diagnosis of cystic fibrosis, who had had the disease for decades before, and attributed to other reasons for her lung disease, for instance. Electronic health records we've talked about, and how they will move, especially to incorporate, I think, data beyond just the health visits. Environmental influences on health are important to capture, moving to geocode-based exposure linkages, but also real-time exposure monitoring, precision nutrition. And then, we'll have more wearable sensors. Many of us are choosing to wear those. We can imagine, those actually being part of prescriptions as well. So next slide. I just wanted to call out, sort of the number of global components to this. This map is of the international 100,000 person plus cohorts consortium, which are basically choosing to work together and find ways to work together across common protocols, common data models, APIs, infrastructures, working with groups like the Global Alliance for Genomics and Health, and other efforts to try to find ways to work together and to hopefully elevate the ability to answer these questions. These will live in not one harmonized data silo. These will live in multiple federated environments in a cloud model, I believe, with common APIs, infrastructures, data models to allow us to query across them and build infrastructures in front of them to allow common questions to be answered, much like my PhD students was able to do to replicate his work from a single site in a rapid time. And I think that will help us answer more questions quickly over time in a truly global community, has clearly been highlighted and emphasized by COVID over the last year. So next slide. So thank you for your time and attention. I'm happy to answer your questions.
Thank you, Dr. Denny. That was amazing and tremendous treasure trove of biomedical technology and data. Let's see if we have any clarifying questions. You can raise your hand. I see one, Kathleen Blake.
Yes, thank you so much. And it's exciting to see all of the progress that's been made. I have to ask the difficult question about cybersecurity breaches. And the reason for that is yet another report today that there have been 6.9 million healthcare data breaches in this year alone. And so I'm wondering if, number one, you're able to comment about the experience so far with cybersecurity breaches, how many of the bad guys are knocking at the door, and also the involvement across the federal government with recent major breaches from foreign actors.
Yeah, it's a great question, and one we all, anyone collecting data has to think about. You know, it is something that we have sought to be, even from the beginning, recognize this could be a target for national actors. It could be certainly attacked from a number of different viewpoints. Fundamentally, we believe that if you look at, for instance, the most recent Microsoft example, you know, it's the cloud-based models tend to be more secure than the locally installed models because you can find, patch, implement, and close off doors faster. And so we believe that moving to a cloud model, thinking about least privileged access, continuous monitoring of systems, and you know, having both, you know, something we've done is both lots of, you know, checks, third-party companies, that sort of thing, validating us, but also having, you know, sort of the open white hat, you know, competitions that get people to try to find vulnerabilities or systems with bounties as a way to help improve the system. All those things being said, of course, you know, we, like anyone else, is potential for that. So you try to minimize the risk. You try to limit what they could get if they get in there, and then try to find and correct the answer as quickly as possible. And then be transparent and honest with your participants. You know, we tell them, you know, in the online process and when you join that nothing is foolproof, and we'll promise to let you know, you know, we're going to do the best we can, and we have you know, videos on it, education around it, but I will also let you know if anything happens. And there are ways you can, you know, there's lots of detail there, but it's something that we as a community need to do more about, and it's always a moving bar.
Thank you.
Sure.
Your Embry.
Yeah, thank you. Great presentation, as always, Josh. Just a question, maybe picking up on toward the end of your talk there, where you were alluding to, you know, the many different data assets that are growing internationally, and I know you've got an eye on, and I think, you know, your correct points about federated solutions and the like. When as you're thinking about the future for all of us, in addition to the All of Us program per se and expanding that network, how do you think about an approach, the idea that we should be coordinating and leveraging a lot of the other sort of local investments and other initiatives that are related to but distinct from all of us? How do you think about leveraging that?
Yeah, I think we need to figure out ways that we create, you know, more and more on-ramps and common protocols and standards. So it's kind of, as much as we can either, you know, partner with vendors making infrastructures that can be reused to create those on-ramps. I mean, I think Odyssey is a tremendous example because the community has self-assembled and started mapping things to common ways and making it all better. And realizing that kind of all boats rise as you do that. But we'll have to continue to work through those kinds of things. And there's some incentive pieces that we need to work on. So if you think about the individual site investing in something, how do you incentivize them to want to participate in this kind of thing? And it's certainly something that IHCC is thinking about, and it's a very important piece as well. So things seem to be heading in the direction that we realize we can't answer the questions on our own. We have to answer the questions in a collective process, and that's the start of, I think, making things better for all of us.
Thank you.
Karen Levine.
Thanks so much. Really, really enjoyed the presentation. And just a question, is there a mechanism for people who are uninsured, not associated either with an EHR based institution or a claims generating system to participate and join all of us?
Certainly. Yeah, anyone can participate. Anyone in the US can participate in all of us. And you do not have to have EHR, you do not have to have insurance. Essentially, we have really sought to overrepresent populations that are typically underrepresented. Now, a lot of people without insurance, having been one of those providers myself until I moved to the NIH, I certainly do have electronic health records without insurance, but certainly none of that is a requirement for all of us.
And is there any, how are you sort of promoting this or propagating the information that enables people to, what's your communication around this?
Yeah, it's through a number of different essentially awardees. And they all have different strategies. So we funded a lot of community groups. We have like the National Network of Libraries of Medicine. We have different participant advocacy groups. And then we have 50 or so, or that number's probably off, healthcare centers that are funded as well. And then they promote through their communities. And so geographically, we have people from all 50 states and territories, but you don't necessarily see the same amount of outreach in all areas based on where we have funded partners. But it's open to anyone. That's certainly anyone that finds the website, and we have done some providers that truly have national reach in terms of letting people know.
Well, thank you, Dr. Denny. Thank you for your presentation. Sure we'll hear more from our stakeholders. So let's move on. Our next presenter is Dr. David Mulstein, who will talk about optimizing value.
Thank you, and it's great to be with you all today. And I'm excited for the chance to talk about value. I spent a lot of my time studying this, thinking about it, and trying to understand what's going on. At the very beginning, I just want to define what value is and think of it as value is improving our outcomes and reducing our inputs. So we want to get more for less, or better outcomes at the same price, or same outcomes at a lower price. Those are all different ways that you can think about value. One of the things that I'll posit right at the beginning is based on a proverb that is the idea that the best time to plant a tree was 20 years ago. The second best time is now. Now, this is the idea that many of the problems that we're seeing in healthcare today are a result of decisions that were made decades ago. And the right time to have fixed those was decades ago. But we need to recognize that not everything is as a plan that's in process. And so there's things that we can do today to prepare for fixing things in the coming years. If we go to the next slide, I'm going to give an overview of 3 different things today. And we don't have a lot of time, and so we'll have to go relatively quick. I want to talk about the need for value. using value almost as a euphemism for lowering costs. Why do we need to lower the cost of healthcare in America? I want to talk about what we've seen with certain interventions around value and what we're seeing in results. Are we seeing some promising outcomes so far? And finally, I want to talk about what it means to optimize value in the future and hopefully reframe how people are thinking about value. Next slide. The need for value is looking at where we are today and also starting to hypothesize of where we want to be in the future. And I think that it's going to be important for people to understand where the United States is. And so many of you have seen Sesame Street, and there's a song that Ernie sings that says, one of these things is not like the other. So if we go to the next slide, you'll see where we are as the United States. The green is the OECD average. This is the Organization for Economic Cooperation and Development, so industrialized countries. And you see how much as a percent of GDP do these countries spend on healthcare? It's 8.8%. The United States is significantly higher. It's twice as much as the OECD average. On the next slide, we see how it's directly impacting the United States. So here is a decade level view of how much we spend as a percent of the GDP. That's what you see in the orange. 1960, so 60 years ago, we were spending 5%, and now we're approaching 18%. What's more troubling and why there's a need to act is what we're doing from a federal government perspective. In 1962, the federal government spent 2% of its spending on healthcare, and now it's over 30%. So it's been growing much faster than just the total spend of the GDP. And if you remember, in the United States, the government only directly covers about half the population. This is through employees of the federal government, Medicaid, and Medicare. And so a significant amount of the total spending has to come from other sources, from the private sector, from employers, from individuals. So there's a lot of money that's going into this pot. But because of the amount that the federal government is spending, it's driving changes that we need to think about from a policy perspective. Next slide. As we think about this, we think, how did we get here? And it's really simple. It's the compounding impact of interest. If we look at how much the cost of medical inflation has been growing above that of total inflation, we've seen that over 70 years, we've averaged 1.7% higher. Now you might say, well, what's 1.7%? It's not very much. But over 70 years, that rate is that if we had grown at simply the same rate as general inflation, instead of spending almost 18% of our GDP on healthcare, we would be spending 5%. And we've been able to consistently do that. And even in recent years, while it has dropped a little bit over the 80s and 90s, we're still spending 1.2% or growing 1.2% higher than general inflation. And so this is a trend that's been going on for a very long time, and it's compounded to the impact of what we're seeing today. But there's not simply a one-sided. With all of the growth that we're seeing on healthcare, we also see other things. And this relates to, among other things, employment. On the next slide, we'll see the largest industry in every state in the year 1990. And you'll see that healthcare was the largest industry in just a couple of states. Next, we see how it was in 95, and then we go forward again into 2000, and then we go forward again into 2005. And as you remember right now, we were at a strong economy, but we were also seeing a transition. You can see that there's a lot of healthcare going on, but there was a lot of retail states, there was a lot of manufacturing states. But between 2005 and 2010, we had a recession. And during that recession, retail and manufacturing were hit very, very hard. The next, you'll see that by 2010, we were largely a country where the dominant industry was healthcare. Going forward to the next slide, and then to the next one, you'll see where we are today. This is the most recent data that's available. As of today, 45 of the 50 states have healthcare as the largest industry. That means it's the largest employer. We also think of healthcare as being a largely middle-class job where people can move up. It's not a very low hourly rate in many of these positions. And so there's a strong incentive for people to say, well, we like the economic impact of this. We want to encourage it. But this leads to the challenge in the next slide, which is the inability of the government to address these common pain points. I call it an economic tension. On one side, you say healthcare has become an unsustainably large portion of the economy. And on the other side, you say this has become the primary driver of growth in many of our cities. If you look at healthcare now, you look at many hospital systems and health systems, and they are the largest employer in their market. In many small towns, you'd say, well, if the hospital goes under, the entire town is going to drive up. And so while we think about healthcare as the outputs, we also have to recognize that it's driving many of the jobs, much of the economic growth that we've been seeing. And so where do we want to come down? Do we want to try to stymie the growth, or do we want to attack that underlying fiscal challenge that we have? Well, it turns out that we're maybe not going to have so much time to make these decisions. If we go to the next slide, we'll look at the Medicare Trust Fund. This is how many years until the trust fund, which funds Part A for Medicare, is exhausted. So if you look at this chart, if you go back to 2010, the Medicare trustees projected that it would take 19 years. So from 2010, it wouldn't be exhausted until 2029. By 2012, it was down to just 12 years. And so it was going to be exhausted by 2024. We made some policy changes, and then going into 2020, we said we had 6 more years to figure this out. Well, then a little pandemic hit us, and a lot of the trust fund is funded by payroll taxes. And we know what happened is that there were some both reductions in payroll taxes, but there were also some many people that lost their jobs, were not paying into those payroll taxes. And so in 1 year, we lost 2 years of time until exhaustion. That puts us today in 2021 as 3 years from the projected exhaustion of the trust fund. This is the closest we've ever been to running out of this trust fund that was created in 1965. To put this in perspective, on the next slide, you'll see where we've been, and we've attacked this in the past. The last time that I would say that we were in the closest situation was in 1997. We passed the Balanced Budget Act, which preserved the trust fund for many years, but we saw that before in the early 1980s, and the Tax Equity and Fiscal Responsibility Act, which created the idea of DRGs, and the Social Security Amendments Act of 1983 mandated DRGs, saved us some time before. What we've seen is that whenever we get close to exhaustion, Medicare is so popular that no governing group wants to be the one that's responsible for the end of Medicare. They figure it out. What this means is that we are approaching a policy window where we need to figure out, quote unquote, what we need to be doing to address this crisis. Next slide. So value has been proposed and has been talked about for years as being this approach, this mechanism. It turns out that there is strong bipartisan consensus. It says that we should be improving the value of the care that we are delivering. We should be focusing on coordinated care. We should incentivizing people for the outcomes, not for just the volume of care. There is strong consensus that this is a good policy. We've been doing this though for a very long time. The ACA was passed in 2010, Medicare ACOs first came in 2012. We're seeing we've now seen almost a decade of experience running some of these models. So how are we doing right now? Next slide, we'll see how they're growing. The orange line is looking at the growth of ACOs, and I use ACOs as a proxy for value-based care, something that we can track. But we can see that the peak of ACOs was in the beginning of 2018, and since then we've actually seen a decrease in the number of organizations that are joining these. This doesn't mean that people that become an ACO stay an ACO, and it actually turns out there's a lot of churn. So while there's been just a slightly decrease in the number of total ACOs, we've seen over 100 organizations that have left and have been replaced by 100 that have come in. And so we're starting to see people that are churning through this model. When you look at the total size of this, it's 36 million lives, which is important. It's 11% of the total US population that is covered under one of these risk-based models, but that's still only 11% of the lives, and we've hit a plateau. So the questions are we going to drive this? Do we want to expand the growth of ACOs? Do we want to expand other alternative payment models like direct contracting or other mechanisms? Or do we want to think about things in a slightly different way? It's important though to know how we're doing. On the next slide, you'll see that we have been seeing improvements with ACOs. So if we go to the next one, this is looking at how we have performed, and this is looking at the Medicare ACO program over time. So don't know if you're seeing this, but we should be seeing a slide that's looking at the Medicare Shared Savings Program. There we go, thank you. This is looking at the overall all-in performance relative to the benchmark. What it means is that for the first 4 performance periods of the ACO program, we actually saw a slight loss. So when Medicare paid out bonus payments, they were being more than offsetting the increases they saw in terms of better outcomes. The last few years, and 2019 is the most recent data that we have, we say, well, this is good. We're starting to see savings, and these are in the tens and sometimes hundreds of millions of dollars that these savings start to accrue. What's important, though, is to look at that total impact. 0.83% is still less than the difference between medical inflation and total inflation every year that we're seeing. And so while these models are good, and I don't want to underestimate the importance of these successes, they're not solving this cost problem. And they're diminishing it, but the cost problem is still there. So let alone not rolling back these cost increases, we're still growing higher than general inflation. Now, Medicare is not the only one. On the next slide, we'll look at the best studied commercial model. This is the alternative quality contract in Massachusetts. It's been going on for even longer than the Medicare ACOs. And you'll look at over time, there were initial high upfront costs where they were losing a fair amount of money for most of the participants. But then the second half of the model, once they get to what I would say more of a steady state, the savings tend to be about that of Medicare, a little less than 1%. So my belief is that while these models are good and we're learning a lot about the delivery of care and how we're changing that, we still haven't cracked the nut. We haven't solved how we're going to change the delivery of care in a way that's going to meaningfully lower the cost of care. So this brings to the question of what should we be thinking about value going forward? Next slide. When we think about optimizing value, I think we need to think about what's going in and what's coming out. And beyond just the inputs and the outputs, we need to think about what's happening while we are inside that system. What does the system itself look like? Next slide. What I want to do is differentiate between what I call the little v and the big V value. Little v value is the focus on improving the encounter. A lot of this overlaps with continuous quality improvement. This is how for that patient encounter do we have a better outcome? Do we have lower inputs? This could be everything from using a new technology or to improving our supply chain, lowering what we need to use for inputs. For example, if we can do a surgery and only need 3 units of blood instead of 4 units of blood, that is little v value. Those are improvements, and those are incredibly important. But I want to differentiate that from big V value. Big V value is the focus of improving not just an encounter with the patient, but improving the entire delivery of care. This is the population focus, where we try to better care for direct acute clinical needs, as well as address all other medical related issues in a coordinated, aggregate fashion that is going to change that delivery of care. This is a really important distinction. Many proposals that I hear are people talking about little v. It turns out that forming big V is both significantly more work and has significantly more uncertainty associated with it. Next slide. Uwe Reinhardt is everyone's favorite German-speaking American health economist. And in his book, Price Out, he talked about different facets of healthcare, and he proposed 3, and I've added a 4th. But I think it's useful to think of healthcare as different ways of looking at a similar problem. The clinical care is that point of care when you're working with a patient. You know, are you prescribing a drug? Are you admitting them to a hospital? It's how you care for a patient when you're directly treating them. The structure of healthcare is the organizations, the companies, the supply chain. How does it all work together? How do these pieces fit? Financing is who is paying, what they're paying, and when they're paying it. And regulation is how are we organizing this and structuring it both from a federal, a state, and a local perspective, and making requirements and expectations that are playing out of this. Oftentimes people have a single viewpoint that they're very comfortable with. Physicians tend to do it from the clinical care because they spend most of their time taking care of patients from that viewpoint. And then to a lesser extent, they're familiar with some of these other pieces. Policymakers or staffers on the Hill look at it very much from the regulatory side. How are we looking at it and structuring and creating these policies to try to improve healthcare? What we need to do, though, is think of these all together and recognize that historically people have not been thinking about them consistently as part of the same system. They're thinking about them from very different perspectives. If we can't bring all of those facets together, we're going to have a small v approach to healthcare. What's fixing an immediate pain point or a problem that we're seeing today? On the next slide, we're going to see the historical view of thinking about value-based care. I call this the traditional theory. It's the idea that we need to pay providers differently for care, then they're going to change the delivery of care, and that's going to lead to better outcomes, better experience, and lower costs. There's a number of different challenges of this. One of the least of which is that there is no magic light switch that you just pay somebody differently and dramatically they change everything about providing care. Most people, when they are in that point of care with a patient, try to do the very best they can for that patient. So where does this lead to challenges when we use it from this mindset? On the next slide, I'm going to use an analogy. And many times we say, look, from a financing perspective, we're overweight and we want to lose weight. And there's different approaches that you can do with it. Now, if you are trying to lose weight and you keep eating at a buffet, there's two things that you can do. One is you can change the options on that buffet. You can try to just change what you can choose from. The other option, which requires considerably more effort, the next slide, is we don't change the options on the buffet, we change the restaurant. Now, from a delivery perspective, this means that we rethink what healthcare is. We rethink the models that we've been built. We reevaluate the structure that is in place and has been formed over the past 60 years. Next slide. When we limit it to payment models, we tend to think of a progression. There's episodic-based models you see on the bottom, and then there's these population-based models on the top. You move from fee-for-service to care management, pay-performance, ultimately moving to shared savings and capitation. And so the mental image that people have is they say, we're on a journey. We've started with fee-for-service, but we're going to take our healthcare system, our physician group, our hospitals, whatever it is, and we're going to start moving more to a different model. And so I think of this as climbing up a mountain. Next slide. Initially, we start next with fee-for-service. And this is just the true, we're getting paid for volumes of care. We're not worried about the outcomes. We just want to put more heads in beds. Next slide, we move to pay for performance. We're being evaluated something on the outcomes that we're creating. A lot of MACRA that we remember from 2015 tends to address this. It's let's at least measure some of the outcomes and make adjustments to pay based on these. Next, we then have a shared savings model, which is let's aggregate the total cost of care for a population. And let's try to figure out what are we doing all together? What are we doing to manage these? And how are we going to, how we change this care? The challenge that I see is that when people get to this point, they say, well, naturally, what we want to do is move to more prospective payments. We want to manage people consistently, accurately. We want better outcomes that are going to be preventing care, focused on the needs of the population, et cetera. Well, when you zoom out a little bit, next slide, you find out that we've been building on the wrong mountain. We've been making all this work, learning how to mountain climb. But when we get to that peak, there's another mountain far away that is radically and fundamentally different. When we build things on a fee-for-service chassis, there are things that are built into the model that are very, very hard to change. We have major commitments for fixed assets. We have a supply chain. We have a workforce that we've been developing and recruiting for. We have technology platforms that are really built around optimizing fee-for-service. The different worldview is you say, well, let's not start with what we're getting paid for. Let's start with a population, take responsibility for that population, and then start to address the needs of that population. Next slide. This requires a dramatic change. Oh, I'm sorry, this is the difference between them. And let's go to the next slide. This requires a dramatic change in our worldview. I like to think of the historical one as a capacity-based approach. identify what's well reimbursed, build capacity, fill that capacity. That leads us today where you can't go down any freeway in America without seeing signs for the best cancer hospital, the best heart hospital, the best ambulatory surgery center. Turns out you can get the best knee replacements in any city because that's what the billboards say. This different business model is around identifying what the needs of the patients are, fill those needs, fulfill those needs at the lowest possible price point, and obviate the need for high-priced care. It's really, really difficult to do this. If you've never read this, and you probably haven't because it's not well read, there was a wonderful article written in 2003 in the Millbank Quarterly that's called The Rise and Fall of a Kaiser Permanente Expansion Region. And this talks about how Kaiser went into North Carolina and tried to take the West Coast Kaiser model and establish it there and failed. They failed pretty miserably and then they retreated. One of the things they talked about is they said there were expectations in that market around cost of care and around access to networks, and it was really hard. And so at the end of the period, right before they finally gave up, they tried to move away from a Kaiser staff model to be offering both a Kaiser staff model on one side and more of an open IPA type model on the other side, so that you could go to any provider that you wanted to. You could have a broad network, more of a PPO. And they talked about how hard it was to try to do both of these things because their skill sets were not in a PPO network and how to manage that. They didn't even know how to pay claims, for example. Changing business models is not for the faint of heart and is frankly nearly impossible. Use an example. The largest restaurant chain in the United States and in the world is McDonald's. Billions and billions of dollars of revenue, and they have a business model which is fast food. Now imagine their board of directors said, we want you to take not just your fast food model, but we want you to leverage your facilities, your workforce, your advertising, and create a parallel sit-down dining experience. In fact, why don't you just do it in your own restaurant? So you can go in the front and get fast food, or you can have a sit-down restaurant in the back, next to the play place. This is almost impossible to imagine. They would have to, it's not just useful to use the same employees, you would need different employees. You would need dramatically different facilities for how you're running that. How you pay for it is going to be significantly different. Current healthcare providers would need to do the exact same level of change. Away from this fee-for-service chassis, optimization around acute care, medical model, to moving a population needs-based approach. The facilities are different, the supply chain is different, the employees and the care teams are dramatically different. I don't want to underestimate the challenge of changing business models. So in the next slide, we say, well, what is the new model then? What is this new theory of change? It's not just looking at the payment model and trying to change the delivery of care. We need to look at it from all of the different facets of healthcare. We need to change the regulation. We need to change payment. We need to change the delivery of care. We need to change the technology that we use. We need to move beyond just the walls of the system and integrate more broadly. And we certainly need to change our structure. Reliance on a hospital mentality from the 1950s is still trying to build things on a model that does not work for what our needs are today. You have to remember that when Medicare was established, the life expectancy for most people was below 65 years. How do we do things differently? When we change all of these different relationships, we then need to change our systems, and that's going to create new business models. It's hard, but we're starting to see examples of this. Companies like Landmark Health, Oak Street, ChinMed, CareMore, and others have dramatically different business models. You can't just say something, this is better because. You have to tie it to the business model, because if we don't have a business model that works, it ultimately will fade away. It is my belief that we have to think of healthcare from this standpoint. It's macro, it's hard, and it's certainly not fast. But if we really want to build the healthcare system that we want in the future, that's not only maintaining our costs, but reducing how much we spend on healthcare, we need to be willing to make these changes. Next slide. So we have a fundamental question. Do we take the healthcare system that we have today and try to repair it? Little v value has a lot of repairs that are possible. Second option is we take the general structure and we just try to remodel it. We rip out a few walls in our hypothetical house and try to make things better for where we are today. Or do we create a vision for the healthcare system that maybe isn't going to be for us, but is going to be for our children and our grandchildren, and start rebuilding an alternative model? If you wait for the $3.8 trillion healthcare system to remodel or rebuild itself, you're going to be waiting for a very long time. And the reason for that is because if you are part of the current system, your first priority is that you continue to be part of that remodeled system going forward. But under a rebuilt model, some of what exists now won't exist in the future. But importantly, much of what does not exist now will exist in the future and will be able to provide and fulfill the needs that we really have as a country. Next slide. As we think about the history of healthcare, we should have planted our tree, redesigning and rebuilding business models 20 years ago. But the second best time is to start now. And the trees that we plant this year and next year will really start to build fruit in 5 years and become the dominant model in 30 years. It's my belief that value is not just about the money. It's about reimagining what healthcare is possible to accomplish. And with that, I'll take some questions.
Thank you, Dr. Molstein. Really inspiring talk for the future. Let's see if we have one or two short questions for Dr. Molstein. So Peter Embry.
Thank you so much, Dr. Molstein. That was great. So maybe just one thing I'd ask you to expand a little bit on, which is the, you certainly alluded to this, the empowerment of the individual and the ways in which increasingly we are seeing models arise, putting truly the person, the patient at the center. How do you see that factoring into this? If you could just say a few more words about that.
Yeah, there's a lot of different ways that you can think about the role of the patient. And one of the ones that I think is most enlightening, if you're familiar with the NUCA care model, it's in Alaska and it's a native population that owns this. They said, we're not going to call them patients, we're going to call them customer owners. I think that mindset is really powerful because it's saying, oh, this isn't about what's best for me as a care delivery provider or as a hospital. I need to be thinking about this as the customer and the owner of this organization that I'm building. And there's a lot of things that go into that, but I think it's really starting to reorganize our healthcare system around not just the needs of our patients, but also the expectations of our patients. We don't do enough listening. We don't do enough thinking to say, what really is an ideal healthcare system? It takes time and effort and a lot, I should double underline and underscore this, a lot of effort to rebuild things. So we might as well be rebuilding the things that are actually going to matter to the people that we're serving.
Thank you.
So I'm going to take one more question. Jennifer Bright.
Hi, thanks for the opportunity. Dr. Molstein, I enjoyed your talk, and just to build off what you just said, it seems to me the starting place needs to be better understanding patient preferences and experience. And yet we find that that's typically not prioritized in the research enterprise. It's less well-resourced as a research endeavor. But if that's really if that really needs to be the driver to kind of bridge that gap between those two mountaintops, what do you think is the first step to really increasing the incentive for that kind of perspective? Because it seems to me if we're going to pay for things that matter to patients, we first have to understand exactly what those drivers are for patients and their families. Thank you.
Yeah, there is research that has been done, but there's not enough. I certainly think funding that research is going to be important. I think that we need to be looking at this and having a research plan for each of the different facets of healthcare. One is that delivery side and the expectations that patients have with it. we equally need to do as much on the structure of it. And then understanding and doing assessment of our regulations and how they're working and how they're not. You look at a law, and very rarely do people that are making policies spend the time to go back and say, what was the actual impact of the law that we passed 10 years ago? And then the payment models as well. I think we need to have a research agenda in each of these different areas. And one of the important ones that I think we don't do enough of is we too often just look at the United States. There is a lot to be learned from other countries. We're not the only country that's struggling with this. We can learn what other people have had successes with and where they've had failures, so we can learn from their successes and avoid their failures going forward. But I think we need research plan across all of those facets.
Thank you, Dr. Mulstein. We're going to move to our final speaker, who is Dr. Kaushal. So Dr. Kaushal is going to talk to us about infrastructure.
Terrific, thank you. Those were tremendous talks, and I'm in the embarrassing position of trying to play wrap up now. So my topic is on infrastructure. Next slide. I spent a little bit of time defining infrastructure because the term is a little bit amorphous. And my definition is something like this. We have people, certainly our workforce of clinicians. We have patients. I use people again because, not every person is a patient. Families, researchers, community organizations, and so on. They generate real world data. We heard a little bit about this via Josh. Clinical data through EHRs, social determinants of health, claims data, administrative data, omics of all types, patient-reported outcomes, patient-generated data, environmental data, and increasingly, there's consumer information available for us in healthcare. Systems, organizations of people, institutions, and resources, and I'm really focused here on the systems of healthcare delivery and the systems of public health. Evidence generation, scientists doing classic prevention, screening, diagnosis, and treatment, an increasing but still limited amount of effort on health disparities and equity. And I think a very good move from looking at quality of life to now looking at patient-centered outcomes more robustly. And then the rapidly but still evolving field of implementation science. And that's the way that, improvements in both healthcare delivery and public health actually happen. Classically, we've known that it takes 15 years or so for scientific evidence to reach practice. That happened much more quickly during COVID, of course. And I think overall that pace is becoming more rapid, but a lot of work still needs to be done in terms of implementation science. Next slide. 2007, the National Academy of Medicine came out with a Learning Health System report. And I want to go through that, somewhat quickly, because there's 2 points I really want to highlight as we start to think about where we need to go over the next 5 years. So in learning health systems, people, next click, generate real world data, again, much broader than clinical information, and in my mind, really inclusive of geospatial information, environmental information, patient reported outcomes, and so on. Next slide. And then, Josh touched on this as well, but what needs to happen for real world data to become research ready data is the transformation that occurs as informaticists, including folks with AI specialization and biostatisticians, morph that data. So, introducing electronic health records was great. Interoperable electronic health records was even better in terms of driving forward clinical care. But that data is not ready for research, and a lot needs to happen to make it ready for research. And that includes introducing common data models. That's what PCORI, N3C, are doing. It's what Odyssey does, and it means that we're structuring data in ways that everyone can use it and know what a certain field represents. It allows that data to be linked. It allows which enables interoperability of it, and it often layers a layer on it of not only quality assurance, but actual data curation, so that scientists and quality improvement specialists know what that data is meant to reflect. Next slide. Scientists then can generate evidence on many different topics. Next slide. And then again, the other point I really want to emphasize, where I think we need to do a lot of growth, is this concept of implementation science. How do you take the evidence that's been generated and really translate it into practice? This was classically known as quality improvement, and I think it is maturing into a scientific field of inquiry itself, known as implementation science. So next slide. So as I go through the second half of my talk, I'm really going to focus on research-ready data and evidence implementation. Next slide. And I think that COVID-19, of course, is a tremendous example of infrastructure and how it supported our ability to respond to this pandemic. And I use the "our" there very, very broadly, both as people as well as healthcare delivery folks, public health specialists, scientists. And I think what it laid bare was that there are parts of our infrastructure that are tremendous, and there are parts that need a lot of attention and improvement. So I'll just go through these bullets somewhat quickly. In terms of diagnoses, testing came out really early. We had really good testing assays with high 90% sensitivity and specificity. In the, I'm biased. I'm in New York City, so I consider the epidemic is starting first week of March for us, and I can tell you that we had really great testing assays by mid-March, and those were up to scale by the end of March. New therapies, I think that this was another area of success. We had clinical trials on completely new therapies, such as the monoclonal antibodies within the first months. I even think that our ability to do pragmatic trials on hydroxychloroquine was an example of a success. So the hydroxychloroquine story is that there was chart review data very early on that said this was a very effective therapy. That chart review data had tremendous biases, and pragmatic trials were set up all across the world. The infrastructure worked for that. Those trials were done within 6 to 8 weeks of hydroxychloroquine coming out as a potential therapy for COVID, and it demonstrated that it wasn't very good. Precision care delivery. We weren't perfect on this, but we weren't terrible at it. And when I use the word precision care delivery, it means using multiple sources of data, not just omics, but multiple sources of data to tailor therapy. And so I think that pretty early on, we understood if you have a high viral load and you have this multitude of clinical and social risk factors, you should be intubated a little bit earlier. And those types of decisions were being made. Disparities and equity, we demonstrated there's the disparities and inequities. I don't think we've pushed the needle in trying to address those. And for me, that has been it's been a failure, frankly, of our response to COVID-19. And then the vaccinations, again, we've had tremendous success, tremendous failures. Moderna, Weill Cornell participated in the phase 3 for Moderna. We enrolled 120 patients in August and early September. The vaccine was approved, of course, in middle of December with FDA EUA. And it's taken till now to really get shots into arms. You know, this weekend was fabulous. 3 million shots Saturday, 3 million shots Sunday. That is fabulous. But it's taken us a while to get there. And I consider both the vaccination piece and in many ways the disparities and inequity piece a failure of our public health infrastructure. I will return to this theme at the very end. Next slide. So I'd love to spend the next, 5 minutes or so really talking about how infrastructure drives innovation and discovery. PCORI, I think, personally did something that was really quite brilliant back in 2013. And they suggested and then supported the conceptualization of a network of networks across the country that were ideally providing comprehensive, longitudinal, deep data on entire populations to support research, in our case, to support quality improvement or implementation science, and that would be a resource to support not only the researchers at the institutions that were sharing data, but everybody's research. And so this concept of supporting other people's research was part of the ethos. When this announcement came out, I went and talked to 5 CEOs in New York City. As people probably know, New York City is a very saturated healthcare market. We have 5 top 10 institutions in a 10-mile radius. There is incredible competitiveness for patients, for scientists, for clinicians. And there's incredible fragmentation of healthcare in New York City. And so what I suggested to our CEOs is that if we could share clinical data, we could provide much better care and drive the innovation ecosystem. And to their credit, the CEOs bought into this premise. And starting in 2013, we built the trust across our healthcare systems to begin sharing clinical data. In addition to sharing that clinical data, which is structured and research ready, not just the sharing of clinical data, but the sharing of data that is in a format that's really research ready. PCORNet allows us to access exceptional research teams. Many of the projects we support are driven by our academic institutions, but I would say 40 to 50% of them, we are supporting other people's research. Across PCORNet, we have a lot of expertise in integrating research with clinical care. My other hat is that I'm Senior Associate Dean for Clinical Research at Weill Cornell. And this has been fabulous because it's really allowed me to better understand and to change our local ecosystem so that research is done hand in hand with clinical care. And this has started taking on real meaning. Like we have a center going up that is half clinical care delivery and half clinical research. And so that concept of real integration was driven by insight and these sort of concepts of infrastructure, streamlined administrative processes, and then true partnership with patients. And I just want to spend a minute on this because I think that there is a lot that is discussed about patient engagement and patient-centeredness. I have learned a tremendous amount through my involvement with PCORI about what those words mean. And we have really tried to incorporate the concepts of patient partnership in a very real way throughout Insight. And so patients sit on our governance committees. They approve every single research study that we're involved in. They often choose the outcomes or assist us in choosing outcomes. And we have really given them a voice. The way that we've given them a voice, though, is not by isolating them and saying, we want to hear the patient's voice. we bring them together in what we call accelerator teams, which are multidisciplinary teams of stakeholders where the patient's voice is very strong, but so is the clinician's voice, and so are community-based organizations, and so are health system executives, because it seems to us that until we get all of those partners around the table, we can't really drive the research in the ways that we want. Next slide. Insight has 12 million patients. New York City is I guess the term is a healthcare destination. And so we do represent the entire country. Next slide. And then across PCORNet, nine clinical research networks, 2 plans, healthcare plans, we represent the entire country as well. Next slide. What does the infrastructure look like across PCORNet? We think about it as pipes, people, and trust. Pipes meaning clinical data. In our case, it's the largest urban clinical data mart with 12 million patients, deep informatics expertise, alignment with international data sharing efforts, integration with the clinical research infrastructures. People, effective and trusting alliances with a multitude of stakeholders, including very much patients and families. And then the engagement of hundreds of researchers, and then trust, getting our health systems to trust that we could share clinical data and have it in a central repository and not utilize it in ways that would be destructive to competitive edge is something that I'm incredibly proud of. We have a tremendous investment by all of our health systems in Insight, and I think that's fabulous. The commitment to supporting other people's research and the commitment to learning health systems with very active improvement cycles. And so we really push for the research that comes through to certainly have a patient-centered component, but as importantly, to have an implementation science component, to go beyond dissemination through peer-reviewed journal publications, to understanding how do we really change our health systems and the ways in which we deliver either healthcare or public health. Next slide. Here's our data. I won't belabor this. I know the hour is late, but it's, clinical data, very importantly linked to geospatial data and social determinants of health, claims data, including commercial claims data, patient reported outcomes, patient generated data, and biospecimens. Next slide. And then I couldn't end a discussion of Insight without our flower of engagement, which again, I won't belabor because I've mentioned this already, but a multitude of stakeholders. I would point out that we consider, for-profit entities important stakeholders, and that includes insurance plans, pharma, industry, because we really believe we need everybody at the table to drive improvements and to do the best possible science. Next slide. Insight in the last 7 years has engaged on more than 300 projects. We don't say yes to every project because there are some times when they don't meet our principles, but we do try to support as many projects as we can. Next slide. So let me end with my conceptualization of the infrastructure we need for the health horizon for the next 5 years. And I'm using terms that have been used already this morning in slightly different ways. So I'll take a minute to define them and then end with just one big thought about infrastructure. I would love in 5 years for us to be a healthcare delivery, a set of healthcare delivery systems and public health systems that are focused on precision health. Precision health, in my mind, is a merger between precision medicine, which I really think of as in a very applied sense. And Josh, I know that you and I are defining these terms slightly differently, but so I will sort of go into a little bit on how I define these terms. I think of precision medicine in applied sense as bringing real world data, including very importantly omics, to bear on the diagnosis and treatment of often life-threatening illnesses. So cancer in particular, I think, is the classic example of precision medicine. I think of precision prevention as taking real-world data and applying it to a population at scale. So I think of it as a combination of precision prevention and screening. A classic example is we know that Asians with colorectal cancer have disease much earlier and a much more severe form of disease. And so as we think about screening guidelines across the country, are we incorporating, and frankly, do we have enough representation of Asian Americans to create screening guidelines that acknowledge where the science is moving, which is a clear demonstration that it's a different disease for certain Asian Americans. And then the merger of these, the marriage of the precision diagnosis, precision testing, precision prevention, precision screening is becoming increasingly defined as precision health. And maybe that should be precision health and healthcare, but that's my vision of where we're at in 5 years. Next slide. And in terms of the infrastructure we need to get there, I think it's really 3 things. It's research-ready data. I think there are more and more efforts underway, but we haven't yet understood how to completely synergize and to really think holistically about real-world data and understand how to make it more readily available for research. I think the second thing is that ensuring in the evidence generation side of things that we have representativeness of patients and patient populations. That's the only way in my mind that we're really going to push the needle in terms of disparities and equity in terms of the science. And then I think that the third is really focusing on implementation science and evidence implementation. So Neil, let me end there and turn it back to you.
Okay, thank you, Dr. Costa. That was terrific. Let's see if there's a couple questions, the clarifying questions. So Peter Embry, you're up again.
Just figure if there's a hole, I'll jump in. I'm sure there's other people. Fantastic talk, just incredible. I really wanted to ask you about one piece that I think is important, but we continue to struggle with, which is the sort of upstream documentation challenges around ensuring that we actually have the real world data that we need in order to be able to not only care for people individually, but then be able to do the downstream population level analyses. How have you been thinking about and addressing that in your learning health system activities?
Yeah, Peter, it's an excellent question. And I think it's a really thorny one because of the EHR market. We were at Weill Cornell, we were a very early adopter of Epic, and we were able to really tailor it in what is now unprecedented ways, because we were that early at the table and had a really great group of informaticists focused on that. This past year, we transitioned for us enterprise-wide, meaning Weill Cornell, Columbia, and New York Presbyterian, to a version of Epic that everyone could be on. and lost a lot of our tailoring. And in losing that, it's making the research a whole lot harder. And so I think it's an excellent question. I think it is one that, you know, we all collectively really need to grapple with, because for EHRs are being purchased for clinical care delivery, but they are one of the most important sources of real world data, and the financial incentives aren't aligned. The people who are purchasing it are, of course, are health systems. Health systems, of course, are worried about clinical care, and the folks that are most worried about utilizing that for pop health or public health, or even for research period, are not the ones purchasing the system. So we have a real misalignment. I think it's an excellent question.
Thank you.
Thank you, Dr. Castle. We're going to move on. I'm going to thank all the four speakers. The wonderful presentations that we have heard have been inspiring and will help us think a way to the future. So what we're going to do, it is now 19 after the hour. We're going to reconvene at I guess 25 after the hour. I should say 25 after the hour, depending on where you are. And we'll reconvene 25 after the hour. And we will hear from our reacting panel and have remarks from them. So we'll see you back in about 5 minutes. Thanks. Hi, everyone. Welcome back. We are now going to have a group of stakeholders who are pictured on this slide who work across the care continuum. And they're going to do some reactions to the presentations that we heard in the prior section, talking about opportunities, challenges, and trends that were salient, they found salient in the presentation, as well as other related ideas. So let me introduce our panel of stakeholders. They are Dr. Karen DeSalvo, who is Google's Chief Health Officer and the former Acting Assistant Secretary for Health at the U.S. Department of Health and Human Services. Next is Dr. Gwen Darian is Executive Vice President for Patient Advocacy and Engagement at the National Patient Advocate Foundation. Next is Dr. Bruce Siegel, who's the President and CEO of Americans Essential Hospitals. And then Dr. Austin Frack, who is a health economist and editor-in-chief of Health Services Research and director of the Partner Evidence-Based Policy Resource Center at the Boston VA Healthcare System. And finally, Dr. Peter Emby, who is president and CEO of the Regan Street Institute, a professor of medicine, associate dean at the Indiana University School of Medicine, and vice president for learning health systems at the Indiana University Health System. Each presenter will speak for about 6 to 8 minutes. And I want to remind them to only unmute their lines when it's their turn to react. So first up, let's have Dr. Karen DeSalvo.
Great, thank you, Neil, and hi, everybody. Wow, what a really incredible set of presentations. And I just want to thank the presenters because I think you covered the waterfront pretty well. You know, one of the things that the NAM PCORI folks asked us to consider was what would the world look like 5 years from now? And I think absent some of the changes that are called for, we could be looking at a pretty bleak picture given the trajectory of the lines in areas like declining life expectancy, exacerbations in health and economic disparities for so many in our communities, as well as increasing challenges in really broadly scoping areas like behavioral health and the social determinants of health that are beyond any one sector. And I think that sort of means that to realize America's paradise, as Rachel said, we have to really think about a world in which the color of your skin, your income, your education, your address is not what is driving or influencing your health outcomes, and a world in which we're really creating a health ecosystem that works collaboratively and is learning such that it's actually really improving health. And we're at a great moment to do that because this crisis has, I think, laid to bear many of the issues that were raised this morning, as well as others, just to help us see crisply and clearly. And if we're not seeing, we're not looking because there's so much opportunity for us to make a difference. So I think my key takeaway from this morning really was that we're building on a broken chassis. I think we keep trying to improve health in this country, building on foundations in some cases that are 400 years of structural racism and systemic racism, not to mention many of the other broken elements. I'll cover just a few of them. And I think that's one important recognition for us, that we probably need to just start over with a new chassis. The second is that we are trying to drive better health care and not better health. And even though I think we often say it's about better health, if you listen to what we say, we easily slip back into this idea that it's about medicine and healthcare and that infrastructure that's so visible and comfortable for us, whether that's the academic research enterprise or hospitals, physicians, or that more traditional kind of workforce. So we have quite a lot of work to do so that we'll stop focusing on the little v, as David said, but really thinking about systematic change. I would maybe use this adage of you're only as strong as your weakest link. And as we think about creating a learning health system that's going to really drive equity and health, we have to think then about where might we have the challenges that we have to address. And we certainly heard about a lot of areas today where we could tackle improvements. I'm going to call out just three of them. One is around data and technology, which in the 21st century, as I think we all know, is just essential to the opportunities not only for precision medicine, but for precision health. But it's an area fraught with inequities. It's a very nice recent Lancet viewpoint that talked about this concept of health data poverty, and how that there are individuals, groups, populations that will benefit from discovery and innovation, but many who won't because of the scarcity of data that tells the story of their health, of their point of view, of their lives. And I think it's a huge threat. I agree with these authors about a threat to the globe's health. I think we heard about sources of data, for example, being the EHR, which is just one slice of a small portion of the population at a moment in time. And I certainly heard some calls for really broadening the sources and uses of data, but frankly, also the ability of people to be engaged in knowing how their data is being used, to having dynamic consent, but then also having access to it because of needs around, for example, just digital hardware and or interoperability tools. I think the second thing I wanted to call out is this area of the non-medical drivers of health, the social determinants, as well as racism. And I think a lot of how we've been thinking of fixing SDOH, for example, has been on how to sort of build up, how to go back to that old mountain and try to do better by it. And really what that often leads us to is focusing on healthcare related social needs and not on addressing really the underlying structures and systemic challenges that we face. The way that we've been medicalizing the social determinants of health also means that the healthcare system not only has responsibility and accountability for it, but also has the financial gain, whereas it's not really shared with the populations that have the most need or with the other care sectors that need to partner with medicine. So I would rather see us think about strengthening those parts of the health ecosystem that can partner with medicine and not rely on medicine to solve all the challenges that we face. So that means strengthening the financial workforce, IT, regulatory infrastructures of the social care system, not only so it can do the work that it needs to do in partnership for people who have acute challenges and hopefully start to move upstream, but also the public health sector so that it can begin to address in a multi-sectoral fashion the structural inequities and do that with a time horizon that's decades and not just a quarter, and do it because it's the only part of this ecosystem that's statutorily accountable for the health of everyone who lives and learns and works and plays in their community. It's not an agenda of a charismatic leader for a short period of time. It's what we want governmental public health to do every day, but it doesn't have the resources and the seat at the table that it needs to get it done. So I think that as we have the opportunity, so I don't want to be negative about this because it's certainly the case has been that we've written a lot of roadmaps for how to improve the data ecosystem to make it more equitable and useful to people and those they trust, how to have a social determinants ecosystem that has got to strengthen social care and public health infrastructure that can partner with medicine so it's not all laying bare medicine. But I do just want to acknowledge that as we do this work, there will be losers. And I think for us, this means we have to consider that there's going to have to be some shifts in not only the financial resourcing of these systems, but in the power of the systems. And that sort of change requires not only will, but leadership that will align these business models, these accountability models, and the way that we think about the benefits, the return on investment, if you will, of having a healthy population in 5 years hence and generations to come. Thank you.
Thank you, Dr. DeSalvo. So next we'll hear from Gwen Darien.
Thank you, Dr. Powell, and thank you everybody for inviting me to make these comments. So when I was preparing over this weekend, I was looking at some of the topic briefs that were prepared by the NAM staff. And I will refer to those as well, because I think there's a lot in those that give us a lot of things to think about. But before I go there, I just want to make some overall comments and then do short comments, because we have a very short period of time, about each of the sections. And I also want to say that we're all coming here with a slightly different lens and a slightly different perspective. And mine is as somebody who's worked as a patient advocate for 25 years, and I'm a 3-time cancer survivor. So I've got a lot of experience with the healthcare and many healthcare systems, and also a lot of experience with my peers and colleagues and friends in the healthcare system. So one of the things that I was thinking about when Dr. Cook opened this session today is she talked about PCORI's mission to move forward boldly and what that really meant at this day and in this time. And I was also struck by the idea that people said it throughout the talks, but we were talking about not just healthcare, but we're also talking about health. And we have to expand the notion of what health is so that it's not just about clinical care. And that's something from the perspective of a patient advocate and cancer survivor is extremely important. And then I was listening to Dr. Hardiman, and I was thinking about her quoting of Toni Morrison. And I think that quote was really the theme for the day: not to do something differently, but to do a different thing. And I think everybody who spoke about that and spoke about how we were going to have to do a different thing. One of the things that I was also thinking as I was listening to everybody, and it's something that also really informs everything that I do, and now the organization I work for provides direct patient services to people who are underinsured and under-resourced for all different reasons. But who do you learn, from whom do you learn, and how do you keep on learning to affect change? And every day, if we don't continue to learn every day, and if we don't continue to question our assumptions, we can never do a different thing. We can just keep on doing the same thing differently, and that not to particularly successful effect. Dr. DeSalvo just said, if we're not listening, if we don't see, we haven't been looking. But I would also add, if we're not listening, we are not learning, and if we're not learning, we're not going to make change. I think about some of the things that have gone through the course of my 25 years in doing patient advocacy. And like many people, because I started out in a sort of nascent phase of patient advocacy, of course, I had no idea what I was doing. I knew that I had an experience I wanted to make better for others. And I also knew that I needed to create a community of people around me. And I learned over the past 25 years, many, many things. But I also think back on some of the incredible failures of learning and incredible failures and what we've learned from them. And I think one of the things that keeps on coming up is that we spent in early years, because I've been working on health equity initiatives since I started in patient advocacy, is that we were so focused on getting away from race as a biological concept that we failed to challenge and dismantle racism. And now we are at a moment where we have the moral imperative to do that. We see this, we have this time, we're called to do this work. And so I think back about that, or I think back about evidence and evidence generation and what is considered to be quality evidence and what is given something on the hierarchy of experience and evidence, and certainly real world evidence and patient outcomes evidence or patient reported outcomes have not been given the value that some other kinds of evidence has given. But yet at the same time, there's always been this idea that we had to create patient stakeholders and patient engagement and patients in the center of all as a equally valued stakeholder. But then that also there has to be a balance between being an equal stakeholder and having evidence that's generated from experience done in a way that is given an equal value. So the values have to align in that way. We also think about, I also thought that this idea of always asking why and always questioning assumptions that Dr. Hardiman picked up was a really critical point. And I think it's something that we just have to keep on doing. It's like, you know, it's like kids asking you why, but we have to do that. That's how kids learn. And that's how we're going to learn as a group and as healthcare stakeholders. So so just to make a few comments on the different sections, when we were thinking about social and environmental factors, one of the things I was thinking about when I was reading and reading the issue brief or the topic brief was really aligned with a lot of what Dr. Hardiman was saying, which is that we have to think about language, and language matters. So some of these things need to be reframed. So in the topic brief, it said access to care, marginalized populations experience decreased access to social protection, insurance, and healthcare due to disparities in economic opportunities and other factors, such as structural racism. But it really should be due to that disparities are due to structural racism and implicit bias, and that leads to disparities in economic opportunity. So we have to flip some of these sentences. We have to start with the framework of racism. We have to center on the experience of people who have not had their experience centered. We also, and then when I think about Dr. Denny's conversation about technology, I don't know whether all of us actually gives people the devices that they need in order to be part of this kind of digital ecosystem and this digital contribution of their digital contribution to their experience in the All of Us research program. But I also think about that, you know, we talk about digital and the technology divide. It's not simply about broadband access, but it's also about the affordability of digital devices, as I mentioned, and privacy and confidentiality. We just did a convening around rural health, and one of the people who was on our panel, one of the patients, had to go out in her car and do the panel from her car because there was no privacy in her home. She had a small home. Her daughter was doing her homework. Then if I think about value optimization, as Dr. Milstein talked about, I think about how we organize around values that matter to patients. And I think about the big V for patients and what that means. And for patients, it's expanding to more than simply delivery of clinical care. It's delivering health. And I think that has been a theme throughout all of what we've talked about today. But I think that his ending really pulled that together. But value is very different for patients than it is for systems, and value is different for communities than it is for individuals. And so we have to organize everything we're doing around values, because values drive value. Infrastructure. I was thinking about Dr. Kaushal, what she was saying about infrastructure, and actually, I heard the last question wrong from Dr. Emby, and I was thinking about he was asking about EHRs, and I was thinking about continuing to follow patients. And so a really important thing is to follow patients by asking them questions that matter to them, that allow them to get to outcomes that are important to them. So I will say I've been treated at 3 different hospitals for my 3 different cancers. And the first one, which sends me a survey of 3 questions, I throw in the mail. I throw in the garbage. The ones that ask me actually meaningful questions that I think might have an impact, I don't care if it takes me an hour to do it. I may be a bit of an outlier, but if you ask me questions that matter, I will answer them. And that's something that we've also found in all of my work. I found that when we've engaged patients and actually asking them to relate their experience and what they would, how they were doing now and what was meaningful for them. And so I think I know I'm going over. I just want to say that one of the things I've been thinking lately is that we've been talking a lot, and Dr. Cook really talked about this a lot, is we talked about we originally used to talk about shining a light on health disparities. And what we really need to do, and what we're really called to do, is to step into the light and dismantle disparities. So thank you.
Thank you, Ms. Darian, for bringing the patient's voice and patient narrative to this conversation. Next, we have Bruce Siegel.
Thank you, Dr. Poe, and those were 4 great presentations, and it's wonderful to be here with all of you here today. I'm going to talk a little bit about those presentations and sort of what it provoked in my thinking, and then maybe end on just a couple of thoughts for PCORI. So, you know, when I listened to Dr. Hardiman's presentation, I thought about taking it maybe just a little step further in that, you know, when we look at structural racism in this country, and many of my comments today will be through the lens of equity in health systems, because that's where I live. I think it's important to also note that, you know, some of that structural racism is actually reflected in our healthcare financing system. I don't think it was a mistake that in 1965, when we made a big move towards, partial move towards universal healthcare, but partial, we set up 2 very different systems, Medicare and Medicaid. One for people over 65 that was federalized, a mostly white population. And then, you know, a completely different system based on the states, which was really aimed at women and children, and often families of color, which was Medicaid. So that structural racism is sort of, you know, even embedded in our financing system. And it has implications, though, for the rest of the healthcare system, because it also created a system where you have these very different tiers of payment models between Medicare and Medicaid and commercial insurance, and a system in which, you know, if you want to be financially successful, you go after commercial covered lives and the high price services that are provided to them. And that has all kinds of implications for outcomes and affordability in our country. And we all pay for that, regardless of who we are. So I just wanted to start on that point. When I, you know, listened to Dr. Denny's presentation, you know, I thought a lot about the promise of technology. The promise of technology, as we saw in the pandemic. I know that, you know, my physician's visits became virtual, and it was wonderful, frankly. I was appreciative of not having to go to my doctor's office, and hope I can continue that into the future and not spend half a day going to her office. And I also thought about, you know, what is the possible application there or benefits there in terms of promoting equity? You know, could these models bring a springboard towards improving access, especially for vulnerable populations? And I hope we can fully, you know, think about that, consider that, and think about models that might work there. But I also, in the area of technology, thought about some of the threats, you know, including the threats to equity. We've already seen how some artificial intelligence tools can actually reinforce disparities. So, for instance, when they, you know, measure severity of illness by resource consumption, which leads to a systematic, you know, measurement of less severity than is actually there for minority populations, so they consume less resources. So how do we guard against that and make sure that that technology does not, you know, broaden these gaps or widen these gaps rather than close them? We came to Dr. Molstein's presentation. I have to admit, I came in sort of, you know, kind of loaded for bear, and he disarmed me. You know, I came in, you know, kind of thinking about, well, you know, value-based purchasing, has it accomplished what we wanted? Is it improving equity, or is it actually, you know, actually undermine equity in some ways? Could it incentivize equity in some ways? And I think by his, you know, reframing of it as rethinking the model, that was something interesting, I got to say, to myself. And perhaps can get us out of this, or I guess, I don't know, I feel sort of this hamster on a wheel, where we continue to look to value-based purchasing to do certain things. It may not deliver, and then we also remain concerned about its impacts on equity in so many different ways. So I'm glad to see that rethinking, and be interested to see where it takes us. And then lastly, in terms of the presentations, Dr. Koshil's wonderful presentation, I wanted to sort of think about that in a somewhat different way. We have a huge crisis in rural healthcare in this country. We haven't spent a lot of time talking about it today, and it played out, we saw in the context of a pandemic. And I don't see any relief on the horizon anytime soon. And I haven't seen any really national policy approach to what we do here. Can infrastructure, can some investments in infrastructure, and I don't mean new hospitals, but I'm thinking about technology and broadband and other ways of doing things, at least begin to address that crisis in rural healthcare. Because right now, barring that, I don't see a huge amount of hope on the horizon. And I hope that, that is something that perhaps could be in PCORI's thinking as it goes forward. A couple other things I just want to mention. In the area of infrastructure, I think as PCORI thinks about its priorities, and I looked at the briefing paper, it's going to have to sort of decide what matters to it. Infrastructure can be anything from clean water to broadband to research network, as we saw, and it's all important. But I think PCORI is going to have to figure out where it brings the most comparative advantage in terms of its tools to helping us figure out a way forward. And then finally, I want to put a plug in for one thing, and that is telehealth. We have seen, I saw in my own hospitals, health systems go from 0 to 120 miles an hour in a matter of weeks during the pandemic in terms of rolling out and using telehealth. If those changes stick, it has potentially huge implications for access and affordability and equity, huge implications for workforce. What's the workforce of the future if telehealth becomes a major or predominant mode of delivering healthcare services? What are the implications for workflow and productivity? And heaven knows this healthcare system needs a lot more productivity growth because it has not seen it, unlike other industries. What are the implications for capital investment? I have health systems already today thinking, what does our future footprint look like if telehealth becomes a major or even predominant mode in which providers interact with patients? So I think all of that is really important. And I think that the tools of CER and PCOR could be very, very helpful in helping us to understand what to do in telehealth, what works and what doesn't, and what makes sense for people and patients. So with that said, back to you, Dr. Poe.
Hey, thank you, Dr. Siegel, and thank you for bringing forth telehealth, that I think was missing in the conversation. So next we will have Austin Frack.
Yeah, thank you. Thank you for letting me join you today. After coming after 4 really fantastic speakers and 4 great responses, it's hard to come up with new ideas. And fortunately, as a researcher overseeing a program that involves about 40 people and editor of health services research, I'm uniquely situated to saying the same thing in a different way. Also, I'm very good at asking questions I can't answer. So no, I am joking with both those things. I hope to provide some additional unique perspective on the things we've heard today. One thing that struck me actually is that structural racism arose in all 4 presentations today, although in some cases somewhat implicitly, and I just want to draw them out. And we've heard a little bit already, but I want to draw it out just to make it a little more explicit, because it's something that I'm passionate about and I'm thinking a lot about, which I'll get to a little bit later. One is data has come up multiple times, data infrastructure, gathering data from different communities. And we have seen some issues arise with using data or collecting or aggregating data or pushing data into algorithms in ways that perpetuate the implicit biases that are already in the system. So I'm all for data. I'm a researcher. I'm a data kind of data nerd. But we have to keep our eye on how it's used and with an eye on inequities and on racism. And actually, I should say, I'm going to say structural racism a lot, but I think we have to pay attention to the other isms, the sexism and ageism and ableism, and there's a whole range of things. So structural racism is absolutely of paramount importance, but there's a lot of other inequities that we know about. Collecting data from various communities, and this was somewhat explicit in one of the presentations, it's absolutely essential that we honor those communities and we return value to them. And that came up and I was gratified to see that. I think that's super important. Another issue that arose in one of the talks, the one about value-based spending and value-based payment and how we get value. And a lot of times what we have seen is when we talk about value-based payment, what it really means is trying to pay less. And a consequence of that we have already seen in some of the pay for performance type programs is that providers that care for Black and brown populations get hit the hardest. And so it perpetuates, again, it can perpetuate inequities that are already in the system. So those are just some of the slightly less explicit ways that structural inequities arose in some of the talks. And of course, it was quite explicit in Dr. Hardiman's talk, which I'm grateful for. And so we've been talking about change. There was a really great analogy to, when's the best time to plant a tree? When's the best time to have changed our health system? It was, of course, decades ago. Well, the best time to have addressed structural racism was centuries ago. But the next best time is now, of course. And now is all we can do. We can't go back in time. So we should be doing that. And change, as Dr. Hardiman said, quoting Toni Morrison, is doing a different thing. And I also think change requires something else. And this is where I'm going to pivot a little bit to maybe a more unique insight, unique to this conversation, not unique to the world. Real change requires being uncomfortable. If you are comfortable with the way things are, you have no reason to change. And we have stakeholders in this system all around it that are comfortable. We have people in our society, some are not comfortable, some are quite comfortable. I'll get really explicit. I'm a white man. It's very easy. I'm a white man, I'm a white heterosexual man. Very easy for me to be comfortable in our society. Very easy for me to not want to change. So the question is, how do we motivate people who are like me in some ways, not like me in some other ways, but in general, for whom it's easy to be comfortable? How do we motivate them to participate in change? Because I think we need everyone's participation, or as many as possible, that's for sure. And many people who are resistant to change are comfortable because they're in positions of power. They have the levers of change at their disposal, but not the motivation. So how do they become uncomfortable? I think this is a really hard question. I think it's an important question. So I can only talk about what I'm doing for myself, because I hear from my Black and brown colleagues and others, naturally they face the isms, the racism and other isms every day, and I don't. So how do I engage it every day? I have to find a way to be uncomfortable with it every day. I think this is critically important. I see my role, I'm a new editor-in-chief of Health Services Research, just started in January. One of the things I want to do is help the research community, or the part of the research community that maybe isn't yet uncomfortable enough, to be more uncomfortable. How do I want to do that? Well, I think we need guidance. I think we need guidance about sources of data. Now I'm getting real down into the nerdy details. We need guidance on sources of data on racism and other isms. How do we measure these things? Where do we look? We need guidance from people who know, from the experts. We need to open the doors and bring them in to our journals and to our communities and listen. We need guidance on how best to use the data, how best to honor the communities from whom it's derived, how to code for racism and other isms, and what are the right methods to use? How do you interpret the results? A lot of interpretation is, and I don't mean this in a pejorative way, is storytelling. It's sort of, this is what the data show, but what does it mean? And a lot of times, papers that use race as a variable, they don't tell the story of racism as a hypothesis about why race matters. I think as a research community, health services research community, or at least a subset of it, has been uncomfortable using those words. And I think we need to normalize that it's okay to say, hey, there is structural racism. Hey, it is driving this thing and that thing. So I would like to play a role as editor of Health Service Research. I would like to see these questions addressed, best practices identified. I'd like to see the communities who really understand how to do this be invited in and given the space and voice to do that. And I would love to see PCORI playing a role doing that, as I would other funding organizations. I think I'll stop there. I don't know how much time I've used, but hopefully there's time for questions. I'm happy to answer them.
Thank you, Dr. Frack, for pointing out all of the inequities in our system and also for starting us on the journey to be uncomfortable. So, next, we have Peter Embry.
Well, perhaps I have both the benefit and the challenge of going last here, but I really appreciate it. And I'll try to focus my comments here on complementing what my colleagues have so eloquently said, and maybe putting some more emphasis, at least from my notes here, on some of the research related items that appear to have emerged from this fantastic discussion. So I'll go down the list. I'll start with Dr. Hardiman. I really appreciated that fantastic talk about the core issues that Dr. Frack was just mentioning again regarding the inequities and addressing those as really being key to improving health. And as Dr. Hardiman so eloquently articulated, I think as with so many issues we have to address, many of these can in fact be addressed with improved technologies and the like, but the hardest part of the solution to even using prevailing technologies and capabilities is usually not in the technology per se. And those of us who work in the fields of informatics and health services research recognize that what I like to say, computers do what they're told and people tend not to. And so it's usually, even though it's not easy to modify our computer systems and the like, at the end of the day, a lot of this comes down to what we choose to do and how we want to use these systems and how we actually want to manipulate them in order to serve our needs as a society and as a health system. And so starting to see the solutions in practice that can actually bring us together to address key social factors, to actually leverage the social determinants of health, bring those together with clinical data, and then be able to target with decision support and other capabilities the improvements that otherwise our systems and our healthcare practitioners are often challenged with addressing. There's more and more evidence that we can do that by leveraging these social determinants, but we have to do that with an eye toward what we're trying to accomplish and a recognition, as has been stated, that there are inherent biases in the underlying data and oftentimes in the way that we've even organized our health systems. And so that brings us to one of the items, which is really about ensuring that if we're going to create this learning health system, there's research that's needed that's sort of analogous to pharmacovigilance around algorithmic vigilance, as I've said before. And that's about addressing these biases, accounting for them as we develop and deploy algorithms and increasingly use AI-driven approaches, and very importantly, to monitor that what it is we're doing in practice with these approaches is actually having the intended effect and is not inadvertently having a negative effect on our patients and populations. Again, there's more and more evidence coming out that that can happen. And so this has to be an ongoing area of study, and I think it's been understudied at this point. That leads to another element, which I think I also heard as a theme in a lot of the presentations, which is about aligning incentives among stakeholders. And I heard that come up, certainly Dr. Hardiman's talk, as well as others, around the alignment of certainly where I sit at the intersection of health systems, the academy, public health agencies, and the community. It's our job to often translate across these tribes, if you will, to make sure that what we're actually doing to change our health system and create a learning health system and make it a more equitable health system is taking full advantage of the various investments that are being made. And right now, I think one of the other things that, again, I think I heard throughout the talks was that these incentives are not aligned. And we do, in fact, have different stakeholders that are not working together. And so a collective investment across health systems, academic centers, payers, industry partners, et cetera, is critical. There's way too much to be done, and we are duplicating a lot of activities across our various silos of excellence, and we need to make sure that we can actually bridge these. COVID, as was pointed out by some of the speakers, has taught us a lot about this. I think Dr. Kaushal made some excellent points about when we put our minds to it, driven by a pandemic and an emergency, the speed with which we were able to address a lot of the core issues, and we were able to move a lot of the bureaucracies out of the way and get things done and advance, for instance, telemedicine and other kinds of approaches, was pretty remarkable. Now, whether or not those had the intended effect, whether they're beneficial or not, I think there's study that's needed there. There were a lot of natural experiments taking place, and I think we have an opportunity to also make that part of the agenda. We don't want to slide back necessarily for in all of these cases to where we were. I think there's a risk of that. But I think it's also important that we study what's been happening, and I think there's some more attention that can be put in there. But there's a lot of overlap and opportunity across what our health systems are investing in, our public health sectors investing in, and our research sectors investing in that requires more alignment. So that brings me to Dr. Denny's thoughts, and among many things, what I took from his presentation was really starting off with the critical element of engagement and how he spoke about the core of all of us really being about that level of engagement, the deliberate focus on diversity, on returning of results, I thought was wonderful to see. And indeed, I think that's another area where we need more research and study around how we actually do engage across all of our activities, the relationship and the participation of people, be they patients or individuals that are intersecting with the health system and with our research enterprise. And this again is an area that I think is critical to creating a learning health system, but we still do this very poorly. We have a need for sometimes I call research services research in addition to health services research to really understand how it is that the different kinds of approaches to engagement of participants in research can actually be improved. And I think we have to certainly do that across the board, including with healthcare. Another key to that is meeting people where they are. And I thought that Dr. Denny also emphasized that very well with the emphasis on mobile technologies. And it brings to mind, the opportunities we have that we need to capitalize on for the increasingly ubiquitous technologies that we all walk around with increasingly on our wrists or have available to us, or all the data that we're generating through our various activities that in many ways can help inform a lot of what's a lot of what our health status really is and what the health status of individuals and populations really looks like, in many ways more so than the clinical data that we have been aggregating and still need to leverage. And so this too is an area sorely in need of research right now. There's a major challenge of making sense of a lot of these data and a huge gap between what theoretically can be done and gleaned from these technologies and these ubiquitous technologies and how they can impact health and healthcare. So I think that's another area that I would put on the list for more emphasis. Also alluded to there was the combining of data sets, and this brings me to one of the other themes around common data models and data standards. I think, again, this is key to advancing things, and yet as common as we like to call them common data models, they're not so common. We have jokes in the standards world about, well, the nice thing about standards is you don't like the one you've got, there's plenty of others to choose from. And that's not really conducive to the kinds of things that Dr. Denny was pointing out. Now, clearly we've made a lot of progress here, but there's a lot more to be done. And PCORI certainly has advanced a lot of this, and I think there's still more work that can be done there. So really aligning the research to be able to determine how to improve that, and then how to align incentives is important. And then before I move on from Dr. Denny's comments, the other thing that came up in the Q&A around how it is that efforts like All of Us and other initiatives like that can not only independently advance our knowledge of what it is we're trying to accomplish, but also importantly by combining not only the data assets and the capabilities, but also the approaches with the other kinds of initiatives that are happening across our organizations, I think is another great opportunity. So how do we take the leadership of initiatives like All of Us and then have that inform regional and localized efforts in precision health? I think that's another great opportunity. moving on then to my comments about Dr. Molstein's talk, which I also really appreciated. I think that for me, one of the critical points was the further emphasis on the importance of aligning incentives and agendas across research, quality, and value. And doing that in order to be able to create this new paradigm that is needed. And I think he made a strong case for. We have to do this because, of course, we are significantly funding, and certainly I see this in my day job, the amount of resources that are being spent by our health systems on more traditional approaches to quality improvements and lowering costs is enormous. And boy, what a missed opportunity not to have that be fully leveraged and aligned with the work that is often being done by the health services research community and the implementation science community. So I think there's a really wonderful opportunity there to say, how do we take the vision of what it is we need to be doing from the perspective of the health system leaders and the academy, and figure out what are those best practices? How do we actually achieve that paradigm shift so that we can create a learning health system that actually brings value to the organization, makes it more sustainable, and leads to the kind of infrastructure and capabilities that then allow us to more systematically learn from every patient encounter, from all of our experiences, and be able to then drive that into discoveries and evidence that can be brought back to practice. And so finally, then that brings me to Dr. Koschel's talk, which was really focused in then on couching the infrastructure discussion around people and real world data, systems, evidence generation, and implementation. And I thought she, very eloquently walked through that in terms of the experiences in creating and realizing a learning health system and how challenging that is to do, but how critical it is to do in the real world. I think, as she pointed out, the incredible lessons that we can learn from a lot of these natural experiments in COVID that have happened are again, emphasized to me and are important, so we don't slip back into the old normal pace, but instead sort of learn from this and are able to continue to shorten that translational window. But that means that we need to study what worked, what didn't, what's better. And I thought the example of, for instance, the clinic that is half care, half research was wonderful to see. That kind of an example of where we are working simultaneously to not only take better care of individuals by bringing evidence to practice, and certainly there are ways in which we need to study how we can do that better, but that we can also use practice to enable evidence-generating medicine, evidence-generating practice, so that we are in fact using those as opportunities to learn. I think there's a lot of research that needs to be done, and PCORI could have a really critical role here in figuring out how we actually enable that paradigm, so that the real world data that's generated, like from EHRs, is actually collected in a way that doesn't increase burden, that doesn't increase burnout, very, very importantly, but does in fact lead to more consistent and useful information that then allows us to be able to draw conclusions and perform the analyses we need to perform in order to be able to learn. And that the research into how it is we will create an evidence-generating practice paradigm alongside the evidence-based practice paradigm, I think is in need of more attention, so that we can have better real-world data for research and then be able to sort of create that virtuous cycle of evidence. So in conclusion, for me, one of the key takeaways in reacting and listening and being ready to react to this was the need to really bridge the traditionally separate parts of our healthcare ecosystem, overcoming these silos between, let's say, the operational health system and the academic systems, so that we are actually performing more as a collective in order to determine what are, in fact, the key best practices, what is the applied research and development that needs to happen in order to improve the health system, so that as a society driven by data, technology, and realigned incentives, we can recognize what it is we're trying to accomplish, and we can do it in a way that's affordable, because we certainly can't afford to do these things in parallel and have them be disconnected. And I think there's a big role for this enterprise in that. So with that, I'll stop.
Thank you, Dr. Emby. So we have a few more minutes. Let me ask our panel of reactors, since you've heard from each other, do you have anything else to offer?
Hey, Neil, maybe just one thing that has to do with the approach to building evidence, and that is it was raised about the time, what we've learned in COVID to more rapidly get information into the front line so it can be useful. And I wouldn't want to lose that thread, because we've learned we can, and we've learned we can be more transparent in the ecosystem, publishing protocols, preprints, making that information available, open source. So that there are many ways that I think we can accelerate evidence into field. Also, though, I think there's a real need and opportunity to strengthen our ability to do embedded science, so that we're learning as we do, and that's a critical part, I think, of a learning health system. And I will just take this minute to make my other point, which is what I want us to build, because you heard this throughout, is not a learning healthcare system, but a learning health system. And there are more actors in that than just in the healthcare system. So I hope we all walk away with that appreciation of how important that has been in the conversation today.
Pointing out we need another Operation Warp Speed to get our health and healthcare together.
No, that's okay. We can skip that. We could skip another pandemic.
Yes, that would be good. So I would say the other thing that I think is learning from the pandemic, which is also another example of where we have to constantly question our assumptions. But we think about, there's been so much work on vaccine hesitancy, and we've been doing it, I think, in a lazy way, because there was a narrative that populations that have been historically marginalized or historically discriminated against are hesitant to because of mistrust of the health system. And while that is true, there are certainly areas that are true for that. It also puts the onus on the individual and the blame on the individual and blame on communities for not doing what they need to do to take care of their health. And in fact, as evidence is coming out, it shows that it's more of a political divide in terms of vaccine hesitancy than it is in terms of a racial and ethnic divide. And I think this shows that we just have to keep on learning, but it also shows us places where we can reframe the narrative that we've built in the past and reframe how we think about why people aren't interacting with healthcare, and how we can talk about it as access, affordability, availability issues, not simply a community or personal behavior issue.
Thank you.
I happen to see in the chat here a question about insights for rare and ultra rare. I think we're talking about rare diseases is what I take from that question. Hopefully I've interpreted that right. Happy to say a couple of words about that. So one of the things I alluded to in my comments was this idea that we have to make some decisions about how we want to use our infrastructure and our capabilities and technologies. And one example, and I can actually speak to this myself, I happen to have had a very rare disease, as is the case with so many people, right? They're rare, but people with rare diseases are not rare. So I had a pheochromocytoma, one of the rarer diseases. And actually the diagnosis, as is often the case, was missed for quite some time, et cetera, including at some really phenomenal health systems. And so ultimately, thankfully, I'm here, I'm cured, I'm fine. But the reality is that where the diagnoses were missed, they were missed. And those institutions and those organizations don't have a way to systematically learn about those kinds of things or necessarily improve. The technologies that we have in place typically they aren't really set up to allow for that kind of learning. Whereas the technology that actually can enable that does exist. In other words, data sharing capabilities and being able to exchange information between organizations is quite possible today. We've just decided to use that at the level of individual care, so that when I as a patient go from one organization to another, they can pull my records from the other location for the purposes of individual care. We haven't decided necessarily to use those technologies in order to route information in a way that actually allows us to learn. Those kinds of things are possible technically, and they sort of go back to my other point about computers do what they're told. We have to develop regulations and approaches and policies and the like methods that actually enable that kind of learning so that we get better at being able to identify the rare disease, make the diagnosis, and then ultimately apply the other approaches to be able to care effectively for those individuals who, of course, we want to care for. And so just an example to that question that I thought I would throw back out to the group.
So I want to thank, we've run out of time, so I want to thank our reactors for all the wonderful remarks that have built upon our presentations from earlier today. So I'm going to turn this back over to Dr. McGinnis.
Thank you very much, Neil, and special thanks to all of our presenters and panelists and questioners. What a simply extraordinary morning we've had, beginning with Nikayla's invitation to look broadly and think boldly. And it's very clear that each of you have taken that call to arms, if you will, to heart. And beginning with Rachel's quote of Toni Morrison on doing more than just doing things differently, which set the tone for the day in many, many ways. And obviously, Josh, in referring to the wonders of the All of Us work, emphasized the fact that we have at our disposal through technology, not only a means of better targeting and improving the effectiveness of what we understand about clinical care and prevention, but that there are also more and more on-ramps, as he said, to helping to advance our movement toward a learning health system. David kept up that theme with the emphasis on moving from small v to big V, that is from encounters to people and populations, in which we envision the orientation around the needs of customer owners and ensuring that we're climbing up the right mountain as we move to re-engineer the way that health and healthcare advances the condition of all of us in the population. Renu underscored the importance of precision health and noted how the infrastructure that we have, the available to advance, can move us toward a learning health system, and how as well PCORI can help facilitate that motion in a transformative fashion. And those themes were really underscored by each of our panelists as well, Karen, Gwen, Bruce, Austin, Peter, in which each of them in their own ways underscored the importance, not just the importance, the fundamental challenge of moving away from our silos, which are sometimes represented as the siloing of people, sometimes the siloing of actions, and the importance of engaging and involving individuals, which of course is the fundamental mandate of the patient-centered outcomes research Institute. And throughout all of the comments, what was clear to me personally was the fundamental role that PCORI can play in helping to advance the capacity of our system to move in the right direction. So there's more to come, obviously, and I've no doubt that the session tomorrow will provide a continuation of the extremely stimulating comments and observations at this extremely important time, not only for PCORI, but for the nation. And tomorrow's conversations will take place in breakout groups that will build on the observations today. It starts at 11 o'clock. And I should mention that while the breakout groups are not open to the public, we'll make recordings and summaries available afterwards. So once again, many, many thanks, and to be continued. Michaela?
Thank you so much. I'd like to echo Dr. McGinnis and thanking each of you for the thoughtful presentations on these important topics related to social and environmental factors, technology, optimizing value, and infrastructure, all really critical components to what we think about when we think about PCORI's future. And I also thought the reactors' comments were incredibly thought-provoking adjuncts to these overall robust overviews. And you definitely have given us some bold ideas to think about, and I certainly look forward to the further discussions and know that these insights are going to be really invaluable to our deliberations with our Board of Governors, as I mentioned before, as we work to identify what we're calling our national priorities for health that will serve as those foundational elements for our strategic planning efforts, as well as our research agenda into the future. And so we look forward to reflecting on those trends and opportunities on the horizon that you discussed here and the unique role that PCORI can play given its mission and its funding mandate. I hope that also you found the meeting inspiring and insightful and hopefully spark some additional thoughts for deeper discussions for tomorrow's sessions, and appreciate all the participants as well as those that attended from the public and listened in. And with that, I'm going to turn the meeting back to Dr. Poe to wrap us up for today and provide us some guidance for tomorrow. Thank you again.
Thank you. Thank you, Dr. McGinnis and Dr. Cook. So I just want to go over a few more logistics for tomorrow. Tomorrow will be part 2 of our meeting, and we're going to convene, as Dr. McGinnis said, at 11 Eastern Time, 10 Central, 8 Pacific Time. And we'll briefly outline then the process that our breakout groups will convene. And they're going to drill down into more comprehensive and structured discussions of each topic. And then we're going to have a report out session after that. So although our audience members won't be able to attend the breakout sessions, we will have a session that will start at 12:45 Eastern for the report out. And so the audience can join us then for the report out of the breakout groups tomorrow. And there'll be recordings made available. The briefing book that our participants received includes instructions for the breakout groups and other information that will help you prepare for tomorrow. And we will have slides and recordings from this meeting that will be available on the National Academy of Medicine's website in a few days, so that everyone will be able to review what went on here today. So again, I want to thank our presenters and our reactors for some stimulating presentations and stimulating and robust conversation. And we will see you tomorrow at 11 a.m. Eastern Time. Thank you.